to call the Veteran Affairs meeting to order. Good morning. I call this hearing to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. Before we proceed, I would like to go over a few housekeeping items for our hybrid hearing. First, if you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so these issues can be resolved immediately. Members and witnesses participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee and subcommittee policy that members will remain muted when not recognized, just like turning your microphone on and off during an in-person hearing. This is out of courtesy to all members on the committee, and so that background noise does not interfere with any other member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say. In order to ensure everything members say is captured on the live stream of this hearing, I ask that members pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearing@mail.house.gov. It will be uploaded in the committee document repository. Without objection, members will be recognized in order of subcommittee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. I ask unanimous consent that representatives from the Washington delegation be permitted to join today's hearing to speak to their concerns about the program, should they be available. Without objection, so ordered. Does any member have a question about the procedures for this hearing? Hearing none, we shall proceed. I now recognize myself for an opening statement. We are here, again, to talk about the Electronic Health Record Modernization Program and VA's struggle to get it right. This committee has held 10 hearings on Ehrm, and that's a lot of time for Congress to spend on a single program. And yet, we are still talking about the same issues. The training is still substandard. Change management is still ineffective, and the system doesn't work in a way it supports VA clinicians when it's working at all. And now we're aware that there are major patient safety concerns and that the program has caused harm to numerous veterans. We will hear from the VA Office of the Inspector General about a recent report that identified a major patient safety issue. The so-called unknown queue has contributed to thousands of clinical orders disappearing in an unmonitored inbox, causing numerous veterans to miss necessary follow-up care. This issue has very real impacts on the health and safety of our veterans. The OIG report cites a veteran who missed follow-up behavioral health care due to an unknown queue. It is only because the veteran had enough awareness to call the Veterans Crisis Line that they are still with us. We have also heard from a veteran in Spokane who has recently given a terminal diagnosis. Sadly, his diagnosis was caused, at least in part, by delayed care due to the unknown queue. I am heartbroken for this veteran and his family. This is absolutely unacceptable. He and the rest of our veterans deserve better, and this, I expect that the VA and Oracle Cerner are going to fix this now before any more veterans are harmed. Patient safety has been this committee's primary focus from the very beginning. We have been repeatedly assured that no harm has come to veterans due to the Ehrm program. At our hearing in April, Dr. Ehrm told us that she didn't believe that there's, quote, that there's any evidence that this system has harmed any patients or that it will going forward, unquote. The OIG report paints a different picture for when she and other VA leaders were made aware of the unknown queue and the patient harm associated with it. I am extremely troubled by the lack of transparency. It is problematic, and we've had to hear about this from the OIG report, not from the VA directly. I am even more troubled that the VA seems to want to minimize or ignore the fact that veterans have been hurt by this system. This cannot be tolerated. Unfortunately, I am not convinced that the unknown Q is the only issue that has caused harm to veterans. I expect VA to provide a better, more comprehensive analysis of any patient harm that has been caused by the program and what they are doing to mitigate these issues. Last week, VA and the Institute for Defense Analysis briefed Congress on the IDA's draft life cycle cost estimate for the EHRM program. While the numbers are startling, I am not sure how accurate those numbers are. I will reserve judgment on that estimate until we see the final report and get a better understanding of what it is and is not included in it. On the surface, it appears to be a major cost overrun, but I think it's difficult to call this a cost increase. VA never bothered to do a comprehensive life cycle cost estimate. To me, this is yet more evidence that this program has rushed and lacked through the strategic planning from the very beginning. Last week, we were notified that the VA is delaying all further go-lives until next year. I think we all support that decision. No more VA providers or veterans should be subjected to this dysfunctional program. This is no means for the first delay in this program, but I can't see that any of previous delays have affected any measurable improvements. It is critical that VA and Oracle Cerner take the next 6 months to get it right. I expect to hear what they plan to do to fix this program. On a more positive note, we were notified yesterday that VA has named Dr. David Masario functional champion for the EHRM effort. We're glad that VA providers will have a voice in this program and a seat at the table going forward, and look forward to working with Dr. Masario in the future. With that, I would like to now recognize my colleague, Ranking Member Rosendale, to deliver any opening remarks he may have. Mr. Rosendale.
Thank you very much, Mr. Chair. I appreciate it. And we are absolutely agreed upon on this hearing and the purpose of it today. This is the 5th hearing we've held in this Congress alone for the Electronic Health Record Modernization Program. And serious issues don't still exist, they're multiplying. I want to thank our witnesses from VA, OIG, and Oracle for joining us today. I am disappointed that Deputy Secretary Remy is not here to take responsibility for the very program that he leads. I also want to reiterate my request that Dr. Jill Drain and Ms. Carrie Johnson appear before this subcommittee as soon as possible to respond to the Office of Inspector General's report about inaccurate training information. For a year and a half, Secretary McDonough, Dr. Carolyn Clancy, Deputy Secretary Remy, Dr. Ehrm, and others have assured us that the Cerner system has not caused any actual patient harm. Dr. Ehrm, you testified before this committee in April of this year, and I will reiterate the chairman's quote, "Don't believe that this system, that there's any evidence that it has harmed any patients or that it will going forward," end quote. There can be no doubt now that beyond risk and near misses, patient harm has happened. VA's list of patient safety events includes numerous cases of vital medications refills being delayed. In April, we discussed the veteran who suffered heart failure after his medication fell off Cerner's active list and was overlooked by staff. The OIG just reported on 2 incidents of major harm resulting from unknown order queue. When an order gets lost, it's not a simple administrative error. It can be life-threatening. The OIG report also cites a different incident of catastrophic harm. That means a veteran suffered death or permanent loss of bodily function. I hope the VA leaders realize the gravity of this situation now. I do appreciate that they did the right thing by halting the implementation of Cerner in Boise and Seattle. This is an agreement that I had with Secretary McDonough 18 months ago, that this system would not be rolled out into any other facilities until it was fully functional. And I think that we all should be able to agree that it's fully dysfunctional. Fully dysfunctional, and there's lives that are being risked. The system is not safe or suitable to roll out anywhere else. Unfortunately, we've seen a pattern of VA executives denying reality until the evidence that we've been able to produce proves contrary and becomes overwhelming. We need to deal with reality, not where we would hope things are. The 5 medical centers that are live on Cerner are struggling. VA has only now started to address the critical safety issues in the pharmacy. We've got terrible morale within the facilities that the system is functioning in. I still have not seen a concrete plan to fix referral management, behavioral health, revenue cycle, or dental. The cost estimate, as was just stated, has more than doubled. It's now at $33.6 billion for implementation over 13 years, plus $5.3 billion for infrastructure. Then it's another $17.2 billion for sustainment over 15 years. Even if the program was proceeding successfully, that would be an unacceptable increase. And all the while, the VA continues to enable Cerner by entering into contract amendments to accommodate their deficiencies. I'm not hearing a credible argument for continuing this effort, other than bureaucratic inertia and profit on the backs of our veterans, risking their lives. That is the only excuse that we can find. Vista and CPRS are by no means perfect. It is true that they have been mostly starved of updates for a decade, and some of the modules have not changed much since the 1980s. But every other VA medical center in America continues to rely on them to deliver care. And all the Vista modernization attempts combined cost a fraction of what Cerner does right now. The updates between 2001 and 2010 cost about $600 million. IEHR, which was attempted between 2011 and 2014, cost roughly $1 billion. At that time, the price tag was unheard of. And now we look at that as if it was the good old days. Vista Evolution started in 2014, was estimated at $5.3 billion over a decade. According to the GAO, although VA's accounting is unreliable, costs to sustain Vista have not exceeded $1 billion in a year. The reality is, like it or not, the VA is never going to be able to accomplish a monumental rip and replace of the EHR system. The organization to manage it does not exist and is too destructive. Even after several years of trying to starve and kill off Vista, it still works, and it's much less expensive than any of the alternatives. The responsible thing to do is to stop throwing money at Oracle Cerner and make targeted investments to shore up Vista. Medical centers all over the country and the veterans they serve cannot be left in limbo. Thank you, Mr. Chair. I yield back.
Thank you, Mr. Rosendale. At this time, I'd like to recognize Chairman Takano for 5 minutes.
Well, thank you, Chairman Mervan, for holding this very important hearing. Today, the subcommittee will examine how VA's mismanagement of an IT program has endangered the lives of veterans. Modernizing electronic health records is something that hospitals in the private sector do all the time. This includes modernizing with the Cerner platform. I can only surmise that from its inception, the program management structure overseeing this deployment is completely wrong for VA. The Office of Electronic Health Record Modernization has been a failure. I have no confidence that our committee, nor the Secretary, is being given an honest and accurate picture of how things are going by the program's leadership, nor have we been from the start. VA needs a modernized EHR. Continuing with Vista A is not sustainable long-term. Let me say that again. I do not believe that continuing with Vista A is sustainable in the long term. Despite this, I want to be absolutely clear. I will not sit idly by and allow this program to endanger veterans. Based on the results of this Inspector General investigation and countless messages of concern from frontline staff at VA, It is my intention that our committee work with the Secretary and the Deputy Secretary to hold program officials accountable and demand fixes before deploying to any more medical centers. This will require holding not only Oracle Cerner accountable, but also the leaders of the program office and the contracting office that have been overseeing the contract since it was awarded. Now, one of the hearings I participated in as a member of this committee when I first got to Congress involved examining the failed effort to modernize Vista, a project called Vista Evolution. Here we are, nearly 10 years and billions of taxpayer dollars later, and we are no closer to achieving the goal of implementing a modern EHR, electronic health record system, at VA. Now, I don't need to rehash this, but we know that a sole source contract for $10 billion by the Trump administration raised eyebrows. Not only a sole source contract, but a contract to a company without significant experience working with the federal government. I also know that that VA has spent hundreds of millions of dollars on a program management office contract that is obviously not meeting the department's needs, including, most importantly, the needs of VA's clinicians and the veterans they treat. This means that that VA's contracting office is not doing its job. It is the contracting office's responsibility to make sure that VA gets what it pays for and holds these companies accountable. The status quo of program management and acquisition at VA is not only wasting billions of dollars, but endangering the lives of veterans. Now, VA needs to address the valid concerns that have been repeatedly raised by frontline staff, the OIG, this committee, and Congress. These problems are obviously not features of the system. They are not features of the system. They are defects. I want our VA witnesses here to answer these very serious allegations honestly and take accountability for the mistakes made. I don't want to hear any more excuses. I want action and accountability. Mr. Chairman, I yield back.
Thank you, Chairman Takano. At this time, I would like to recognize my colleague, Mr. Borst, Ranking Member of the Veterans Affairs Committee, Congressman Borst.
Thank you, Chairman. You know, we've got to stop VA from throwing good money after bad. Not only is this project spending money on autopilot, the Cerner system has made VA health care worse. You know, I visited Walla Walla, Richland, and Seattle a few weeks ago, and I got an earful from dozens of staff and even from management. VA has spent billions of dollars, but the result has been reduced capacity to treat veterans and a collapsed staff morale at these facilities. I know our witnesses will challenge the new cost estimates, but before I ask my questions, I want to get a few things straight. The EHR, as it exists now, is already bad investment at $16 billion. Frankly, for what the VA is getting today, it would be a bad investment at any price. The new estimate is $39 billion for implementation over 13 years, and then $17 billion to maintain the system over 15 years. You know, it's hard to even imagine spending that much money. The current system, Vista, has its flaws too. But the Cerner efforts is now 10 times more expensive than the project to modernize Vista and that the VA had abandoned. Cerner has to fundamentally improve, and we have to set a deadline. If we don't see major progress by early next year, when VA says they intend to roll Cerner out to larger sites, we will have to seriously consider pulling the plug. Congress never authorized this project. Once again, let me say that. Congress never authorized this project. So therefore, we carry some of the blame for failing to lead. We have to lead now. I will be writing legislation to do just that. I hope the situation can somehow be turned around. But everyone involved in this mess needs to understand the consequences are real and that there is no blank checks here. Now, the one thing that I've seen is it is the one thing that has been able to unite Republicans and Democrats, as you can see here today. We're all frustrated and we want results. Mr. Chairman, with that, I yield back.
Thank you, Congressman Bost. At this time, I would like to recognize. Okay. I will now introduce the witnesses on our first panel. Dr. Terry Ehrm is the Program Executive Director of VA's Electronic Health Record Modernization Integration Office. She is accompanied today by Dr. Edward Yakul, the Executive Director of the National Center for Patient Safety. Dr. Robert Fisher, the Director of Mann's Grandstaff VA Medical Center in Spokane, Washington. Mr. Scott Kelter, the Director of the Jonathan N. Wainwright VA Medical Center in Walla Walla, Washington, and Ms. Linnell Johnson, Acting Chief Medical Officer for the Ehrm-IO. Also on the panel one, we have Dr. David Case, Deputy Inspector General, and Dr. Julia Krovak, Principal Deputy Assistant Inspector General, VA Office of the Inspector General. We will now hear the prepared statements from our panel members. I will remind you to please pause for 2 to 3 seconds before speaking so that the recording will capture all of your words, and please remember to do so when answering members' questions. Thank you. Your written statements in full will be included in the hearing record without objection. Dr. Ehrm, you are recognized for 5 minutes.
Thank you, Chairman Mervan, Ranking Member Rosendale, and distinguished members of the committee. Thank you for the opportunity to testify today in support of VA's initiative to modernize its electronic health record. As you stated, I'm accompanied here by my VA colleagues, and our panel demonstrates that VA's EHR modernization program is a partnership among VA medical centers, VHA Central Office, and the EHRM Integration Office. I'm appreciative of the continued collaboration with these leaders, and I'm looking forward to working with our new Undersecretary of Health. Additionally, I look forward to continuing to work with you and your staff to ensure that we are successful. We appreciate your support during this challenging journey. I'd like to state up front that we are committed to full transparency with this committee about our deployment efforts. We know it is important for you to get the information you need to perform effective oversight. As a physician and expert in healthcare quality and patient safety, I take patient safety risks and harm very seriously, as do my VA colleagues. I work closely and collaboratively with the VHA experts who review and analyze these incidents. We acknowledge that the first deployment at Mayo Grandstaff in Spokane, Washington was problematic. The events that occurred during the first several months after go-live in Spokane that resulted in any degree of harm to veterans was unacceptable. We are unequivocally committed to providing safe, effective, high-quality care to veterans with the #1 goal of zero harm. Our charge has been clear: create a single, seamless, integrated health record from military service through veteran status. This complete record within a single system allows those who care for our nation's veterans to keep pace with the future and increasingly complex demands of VA's health system. Our nearly 40-year-old legacy system has served us well, but it's reached the end of its life cycle and, given its limitations, needs replacing. A new, modern, enterprise-wide system will support standardization of healthcare delivery and services across VA. Standardization is a key contributor to high quality and safe care, to realize efficiencies, and critically in providing consistent, excellent patient experience for our veterans. I was brought on board to get this effort back on track. I've spent the last 7 months since my arrival to VA assessing what didn't go well in Spokane and planning for doing it better. With a new senior leadership team in place, close collaboration and communication across the department, and engaged site leadership and staff, VA continues to build a more informed approach to deployment. In hindsight, Mann staff wasn't ready to adopt the new electronic health record. Planning was inadequate and lacked a thorough assessment of the site's readiness. And importantly, in October 2020, VA medical centers were still being seriously impacted by the COVID pandemic. This wasn't the fault of the personnel at Man Grand staff. In fact, they've worked hard to continue to care for our veterans under incredibly difficult circumstances, and we appreciate their hard work to ensure our veterans continue to receive world-class care. In the last 2 years, we have learned many valuable lessons that have been critical to our approach going forward. VA documented these in a department-wide strategic review that identified patient safety and other areas for improvement. As a result, subsequent deployments were better planned and executed. To improve communication and collaboration, the EHRM Office of the Functional Champion, the National Center for Patient Safety, and other experts in informatics patient safety within VHA meet weekly. It is our priority to proactively institute measures to reduce risk to patients and not wait for reports of harm to occur. Moreover, our intent is to continue to develop strategies together to protect patients as we continue to plan for future deployments. VA is committed to resolving our challenges. This includes pressing Cerner to make the needed changes within the system to ensure better stability and to accelerate installation of the capability enhancements our medical personnel need to do their work more effectively and efficiently. Also, we are actively resolving the issues identified by the Office of the Inspector General and are committed to working with them to close their recommendations. To be clear, our top priority is and always has been patient safety. In fact, due to concerns at our first deployment site, patient safety and risk reduction activities have been incorporated into every aspect of the deployment effort. Of course, we also know that some level of risk will always be present. That's the nature of healthcare, and we will continue to prioritize measures that mitigate as much of this risk as possible. We are committed to ensuring the new EHR works for the dedicated medical personnel and, above all, our veterans. As in any large deployment effort, we expect to experience bumps along the way, but we are now better organized to respond rapidly because of better processes and communication across the enterprise. Chairman Mervan, Ranking Member Rosendale, and members of the subcommittee, thank you for the opportunity to testify today. We're happy to answer any questions you may have.
Thank you, Dr. Durham. At this time, I'd like to recognize Mr. Case. You are now recognized for 5 minutes. Mr. Case, you are muted.
No, thank you. All right. Chairman Mervin, Ranking Member Rosendale, and subcommittee members, thank you for the opportunity to discuss the Office of Inspector General's oversight of VA's EHRM program and its impact on patient safety. We recognize the magnitude of this project and are committed to providing oversight that supports an implementation that prioritizes the safety of the veterans VA serves. This year, we published reports related to significant patient safety concerns at Man Grand staff, including issues with medication management, patient care coordination, the troubled ticket process, and the availability of actionable quality of care metrics. We are also aware of continued issues with behavioral health services and the pharmacy management software. I want to turn to the 2 reports we published this month. First, the unknown queue. This report addresses one of 60 serious patient safety risks identified by VHA with the new EHR. The unknown queue is a software function that, for a time after go live, was unknown to healthcare providers placing orders. It captures certain orders recognized by the system as undeliverable. Providers placing orders for their patients are required to select the delivery location for that order to be fulfilled. But in that process, if the provider selects a location that the software does not recognize as a match, the order will not be processed, instead going to the unknown queue. Most problematically, the provider was not notified of the routing to the unknown queue. Cerner leaders could not confirm that VA was told about the unknown queue before going live at Man Grand staff. During our exit conference, VA shared Cerner documents that noted a VA employee had approved of its use. But during earlier interviews, that same employee told us they had no awareness of the queue. The reality of the go live at Man Grand staff is instructive. There was no training on the unknown queue, no plan concerning the unknown queue, and no staff had access to the queue. Unfortunately, VHA patient safety experts identified nearly 150 veterans at Man Grand staff who suffered harm due to the unknown queue from go live through June 2021. The current mitigation plan does not eliminate risk, and every deployed site must monitor the queue and address orders in a timely manner. We are also concerned with the VA Deputy Secretary's response to this report that is essentially silent in acknowledging the VHA identified patient harm. Such acknowledgement by senior leaders is critical for VA to function as a learning organization committed to zero patient harm. Second, we published the administrative investigation resulting from our 2021 review of deficiencies in training on the new EHR. This investigation found OEHRM change management leaders provided inaccurate information to us about their plan to evaluate training and how well VHA staff did on the training proficiency checks. We concluded this happened due to inadequate care and diligence, not from an intent to deceive. When we reviewed the training program, VA provided a document entitled Training Evaluation Plan, but we later learned it had not been reviewed, not approved, or implemented. After go live, we asked VA for the raw data they collected, but instead, VA sent us bullet points saying 89% of proficiency checks were passed in 3 attempts or less. Aside from not giving us what we wanted, we further found that change management's leaders initially calculated a 44% pass rate in response to our request. They then removed outlier data they believed were skewing the results. They did this incorrectly and removed all failing test scores from their calculation. Transparency would have made all the difference. First, VA should have told us their training strategy was really in its infancy. Second, they should have just provided the raw data we requested. This episode is concerning because if we had not dug into their data, it's likely that you, VA leaders, and the public would not have learned the truth. Overall, we remain concerned with the number of open recommendations from our older reports. The success of this EHR implementation is dependent on VA's transparency, careful planning, and the recognition and remediation of patient safety concerns, not only of those risks identified by our oversight work, but by VHA's own experts and end users who rely on the EHR for everyday clinical decision-making. Chairman Mervin, this concludes my statement. I would be happy to answer any questions you or other members may have.
Thank you, Mr. Case. We will now begin the questioning for panel 1. As a reminder to my colleagues that members should pause 2 to 3 seconds before speaking so that all your questions are captured. I will now recognize myself for 5 minutes for questions. Dr. Ehrm, the OIG report indicates that you were made aware of the unknown queue issue and patient harm shortly after you started in December of 2021. Why then did you testify in April of this year at our hearing in this committee that you weren't aware of the system causing patient harm?
Yes. Thank you, Chairman Mervan, for that question and for me to be able to explain what happened when I first came on board. I believe the OIG and I perhaps have a different perception of what awareness is. The 2 emails that the OIG cites, I went back to take a look. One of them was a zip file with 29 documents, not one of them titled Unknown Queue or containing discussion of harm. And the second was a 55 slide deck that mentions once the unknown queue, does not describe harm, but describes patient safety reports, which, as you're aware, does not constitute harm. I met with patient safety personnel in the early months that I was here. I relied on our acting functional champion appointed by the VHA to work on patient safety issues, but that didn't happen. So during the hearing, I was factual when I said I was not aware of harm to patients. I was aware that there were a good number of patient safety reports and risk, but when I became aware over time, we have now reconstituted our weekly meetings with the National Center for Patient Safety and with the informatics patient safety experts to devise strategies to protect patients.
Can I ask, so there was too much information for you to read?
There were 29 documents. Not one of them was specific to the unknown Q or describing patient harm. It described risks. A lot of them were emails from providers at Mayo Grant staff, and these
But you
were
had given specific from the OIG, they gave you documents of 29 and 51, one deck and one slides.
No. What I'm saying is, when I arrived on December 20th, on December 23rd, it cites an email that I got on December 23rd from the deputy secretary, which was a zip file. And on the 27th, I received a PowerPoint, and the report asserts that then I was aware of the unknown Q and patient harm. That's not entirely accurate. I did receive documents, though note that...
So is it your testimony that you didn't learn the unknown Q in December of 2021?
I was not fully aware of the unknown Q. However, over time,
How do you
as I was learning
how do you define aware?
either being briefed and having an understanding of the issue.
So you were not briefed in December of 2021 about the unknown Q?
No, I was not.
Okay. Mr. Case, if I may, what is the OIG's take on when Dr. Ehrm was informed of the patient harm from the unknown Q?
We've cited the two emails in our report, the information she was provided in late December. And I would note, in addition to that, that during this period of time, there was active work going on to try to remediate the unknown Q. In February of that year, an alert was put in on the unknown Q. That alert was a remediation effort to address something that was a problem that had been identified up and down at the facility and by the patient safety experts at VHA. In March of that year, there was direct access into the unknown Q. So not only was this information provided to her in the communications in late December, working on the unknown Q and its remediations were being done in that period of time. And that's the kind of information she had. I can't get into the intent or understanding she had in her head, but I can relay the kinds of information and activities that were going on in that period of time.
Thank you, Mr. Case. Dr. Ehrm, do you accept that the patient harm was caused by the unknown Q? Yes or no?
It was a failure of processes
or
and
no?
communication. So yes, because there was a failure in communication and processes at the time of deployment, the OIG is
Yes.
exactly...
So the answer is yes.
Yes.
Thank you. At this time, I'd like to yield to Ranking Member Rosendale.
Thank you very much, Mr. Chair. Appreciate it. Mr. Case, I'm looking at page 15 of your report. On June 23rd, 2022, OIG leaders met with the VA leaders, and Dr. Ehrm reported that work to address the unknown Q was considered complete, and that on average, there were 28 orders in the unknown Q report. However, the morning of the meeting, the OIG generated a report of orders in the unknown Q and found that 522 total orders across 5 VA medical centers. Is the unknown Q order still delaying veterans' care?
The first and easy answer and correct answer is yes, it is. It has the potential and does in fact delay care. That's because the remediation that's in place requires human activity to identify what's in the queue, remove the order, and then reroute the order. So it does result in delay in care with attendant risk.
Thank you so much. I don't see how in the world we can call underestimate of 28 orders in the queue as opposed to 522 that were in there being completely transparent. Dr. Fisher, how many orders roughly still wind up in the unknown order queue on a typical day or week, whichever way you would like to address it?
Sir, that number varies because the queue continues to populate, and then each week we address all the orders in the queue to try to resolve that issue and redirect properly. I get a report every month that tells me what the cumulative total in all the various queues. The unknown queue has morphed somewhat into something like 17 various order queues. The unknown queue is a subset of a larger number.
Well, that sounds like we very well may have another problem. So what is the average of number of orders that are in this queue?
Well, I can tell you what the queue looked like at the end of June. I have that data, if you'll give me a moment.
Sure.
So the unknown queue, the cumulative total at the end of June was 312.
So still a little bit more than the 28 orders that we were cited back in June.
Well, these are snapshots, sir. I mean, it can vary quite widely depending on the week and what is populating that queue at the time.
Sure. Mr. Case, VA's response to your report that the Deputy Secretary Remy signed is a blame-shifting exercise. It literally sounds like, for those of us who are historians, it depends on what is. The precise date when the employees at Mann Grandstaff were told about the unknown order queue doesn't really matter. That's missing the point. The point is that the Cerner system is so mind-numbingly complicated that no one could ever keep track of everything without widespread errors hurting patients, and 149 of them did suffer harm. Please walk me through all the procedures that Mann Grandstaff and other sites have to follow to manage the unknown order queue.
Yes, so, and it depends on what point in time. Early on, there was no awareness of orders going to the unknown queue. As soon as it was discovered, the facility and others worked to remediate that and let people know what was happening. Over time, there have been three major efforts to mitigate the unknown queue. In September of 2011, basically 11 months after go live, Cerner went in and remapped some of the locations so that undeliverable areas for delivery were eliminated. In February of that year, they put in an alert. However, I would note that alert can be overwritten, that things are going to the unknown queue. And then in March, VA got direct insight into the queue and could pull reports as to what was in the queue. Prior to March of 2022, the information on the queue was provided by Cerner as to what was in there. So those are the three remediation activities that are in place now. And I would note that they still entail delay and the potential risk involved with delay. And if this is a safety feature, it's somewhat inconsistent with the notion that a safety feature needs remediation along these steps.
Thank you very much. Mr. Chair, I'm right down to my time, so I would yield back.
This time I'd like to recognize Chairman Takano for 5 minutes.
Thank you, Chairman Mervan. Dr. Yekel, I appreciate you appearing before the committee today. As the Executive Director for the National Center of Patient Safety, I'm hoping that you can illuminate the members here on the results of the Inspector General report and the impact that the system may be having on the safety of veterans. So, Dr. Yekel, would you agree that veterans have experienced harm as a result of this system?
Thank you for that question, Congressman. No technology is perfect. And what I would say is that we do know that patient harm has occurred as a result of the rollout of the Cerner product.
Well, thank you. Have you previously recommended to anyone at VA that deployments of the system be delayed until issues are addressed related to patient harm?
We recommended delays in 2 cases. One is when we had a Columbus go live, and that was delayed because of COVID, and it would have not placed undue stress on staff at that point, because at that point, COVID was peaking in Columbus, and to implement an EHR during that time would have been a mistake. And so we had that general discussion amongst ourselves. Secondarily, we've been working with Ms. Johnson, Dr. Ehrm, and others on a go live readiness checklist. We've included quality and patient safety measures in that readiness checklist. And there were discussions of, well, boys that go live and whether they were ready or not. And happened with the facility and the vision. And that's why we made the decision and recommendation as a team to not go live in Boise. First, to push it back by a month, and then to delay it to the next year.
When was Boise originally supposed to go live? Do you remember that?
I believe it was in June of this year, but I will have to check that and take that for the record.
June
Or perhaps-
26th. June 26th.
Thank you.
Thank you.
Have you received recommendations from other VHA staff to push for the delay in deployment of the system until patient harm issues are addressed?
Yeah, we've had a lot of robust discussions with other VH staff on delaying the deployment of the system. And as a direct result of that, of those discussions, the deployment of the Cerner product was delayed for the rest of the year, as I just discussed. So we're in that conversation. We are having those conversations. Dr. Ehrm and I mentioned we meet weekly. I meet with Ms. Linnell Johnson 3 or 4 times a week. That wasn't present immediately before Man-Glenn staff. So we've really changed the way we communicate to be more transparent, especially around patient safety information.
Well, tell me when those recommendations, when did you hear these recommendations from staff?
It's in a general dialogue when we initiate conversations. There are several go live events that are hosted, and we are part of those events about let's have a discussion. Is the facility ready? What do they have the right leadership mix, et cetera, et cetera. So those are the kinds of, they're iterative discussions. There's no one particular instance.
Sir, I didn't ask you to describe the discussions. I asked you when you heard recommendations. You answered affirmatively that VA staff did push for delays in the deployment until patient harm was addressed. I want to know when you heard those recommendations from VA staff.
At the Columbus site before their go live, when we were having discussions with them, we had preparatory for after Man-Glenn staff, we had patient safety summits. And those summits laid out for all the staffs of Columbus, Walla Walla, and subsequent sites, all the patient safety concerns that we had in the domains we previously described.
And they occurred about what month and what year?
I will have to get back on the specific dates of those
Right.
patient safety summits with you, but they were prior to go live at all the sites. They included members of the VISN and the facilities.
Well, thank you. My final question to you is, from your perspective, what is the best course of action in order to make sure that patient safety and patient harm are addressed before deployment of the system to any new sites?
Sorry, I had to find my mute button. As I stated before, no technology is perfect. We need to continue the collaborative work to get all the stakeholders to monitor the system and hold it accountable. And that's what the National Center for Patient Safety does. That's why we're here. We currently have systems in place to monitor for potential harm and safety. That's why NCPS exists within the Veterans Health Administration. I think transparency on the part of Cerner Oracle regarding the safety features that they have built into their system is critical for us to have, so we can proactively address any potential safety concerns or harms.
Well, sir, I would appreciate more concrete sort of recommendations on what needs to happen. I didn't get any real sense of what needs to happen. I yield back, Mr. Chairman.
At this time, I'd like to recognize Congressman Bost.
Thank you, Mr. Chairman. Dr. Ehrm, the new estimate actually says the cost could be as high as $63 billion if everything goes wrong. And I see a lot of things going wrong. Now, I understand you believe that it'll be lower. What evidence do you have of that?
The IDA report, as you all mentioned, is coming out next month, so it'll be a more complete rendering of their methodology and a better understanding of how they determine their estimates. But I want to make sure people understand that this is a life cycle cost estimate over a 25-year horizon versus our budget, which is a 10-year focus just on deployment. So I wanted to make sure that that is understood. And the life cycle cost estimate, IDA put in there what's called a risk premium, where they gave a range of, as you infer, of if things go 100% right versus, if there are problems and delays occur. So that's how that report was done. But we'll find out more next month when the report is released.
Well, whether it's a life cycle or whether it's 10 years, I think it's pretty high. So how much do you believe is reasonable to spend with Cerna to get this right?
I can't answer that question. We do want to get it right, and we have changed our deployment strategies and our approach. We have also instituted procedures within our program management to help us rein in costs. We're working with VHA to standardize our deployment of biomedical devices and systems, and every which way we want to be efficient and effective, but I can't give you an answer to how much this is worth.
Well, some of us will have to, and we're going to have to figure it out before long. You know, the new cost estimates say right now that Cerner rollout will take 13 years instead of 10. Now, you testified in the Senate last week that it will be shorter than that, but VA is already more than 2 years behind in its original schedule. Isn't 13 years actually probably the best case scenario?
What I have to say to that is that I've been given my direction to plan this as a 10-year deployment. So we are in the process of planning for a 10-year deployment, and we should have a schedule out sometime in the fall. However, that said, as you have inferred, there has been delays, and so it's reasonable to expect that it could go beyond, and we are doing that kind of contingency planning as well as planning for the 10-year deployment.
Yeah. The problem I keep seeing here is that we keep changing and readjusting and readjusting. We're missing the mark every time. And if you say here today it's a 10-year, we're planning on a 10-year deployment, and 24 years from now we're still sitting here going, yeah, there's going to be a 10-year deployment, we got a problem. And that's what we're seeing all the time. You know, VA has been promised that the rollouts will spend up, and that'll speed up and meet the 2028 schedule originally. But you figure timeline, the timeline has been 5 and 10 medical centers going live on Cerner at once. Yet VA just delayed Boise in June because there wasn't enough Cerner and VA support staff to handle it 2 weeks after Roseburg and White City. Doesn't that show the schedule is unrealistic?
The schedule that we're outlining is aggressive, to your point, and of course we are planning for any contingencies, but we couldn't help that there was a pandemic that lasted a long time. We would not want to proceed during a time where there's already great stress on the health system. We are currently in initial operating capability, and these 4 subsequent sites, we have also learned a great deal, and we are hoping to get to a point where we have a system that is replicatable in the same way DoD is doing it in waves. They also had an IOC where they had similar bumps, and so we anticipate we can get there and we can replicate this across the system, whether it's in 10 years, 11, 12, we can do this.
You know, the new cost estimates are $5.2 billion for operational distribution, such as additional staff increases, community care utilization, and revenue loss. In other words, it will cost VA an extra $5.2 billion to shore up the medical centers after installing EHR. Do you have any idea where in the world this money is going to come from? And don't say, well, Congress will just pass it. We've got to try to figure out, because look, these veterans have children, grandchildren, and great-grandchildren, and we're going to be paying for a very, very long time, and it's very hard to justify. So what's your answer for that?
Yes. Well, thank you for that question. Actually, that is a phenomenon, a loss in revenue due to reduced operations in any deployment anywhere, whether it's the commercial sector or VA. And VA is one of the largest, most complex health systems, actually the largest, most complex health systems. You would expect that there's going to be a reduction in our operations. One of the unique things that VA has done, VHA, to their credit, is that they have strategies through their VISNs with clinical resource hubs, as well as a central office, where they provide additional staffing, as you had mentioned, in order to support our medical professionals as they're learning the system. But it is well known, it's in the medical literature, that it could be 6 months or even more. I've read studies from some of the biggest health systems that describe a loss of revenue and a reduction in operations. And I've experienced that myself, having worked out in the commercial sector, gone through these type of deployments. As you're learning the system, you're slower, you can see fewer patients. So that's not surprising, and the $5 billion estimate is not surprising either.
Mr. Chairman, I yield back. I'm sorry I went over my time.
This time thank you, Congressman Bost. At this time, I'd like to recognize Congresswoman Schreier for 5 minutes.
Thank you, Chairman Mervyn, for allowing me to participate in today's hearing. And thank you to the witnesses for being here today. In the past year, we've really witnessed a terrible rollout of the Cerner electronic health record at the Mann Grandstaff facility in Spokane, Washington. The community-based outpatient clinic in Wenatchee, which is connected to Mann Grandstaff, serves veterans in my district in rural north central Washington. Next year, as you know, the system is slated for deployment in the greater Puget Sound to facilities in Tacoma and Seattle, which offer even more specialty services, which generally require higher complexity of care, more orders, and a host of providers shared across the state. And I'm really concerned about these rollouts. Like we've seen in multiple IG reports about the program in Eastern Washington since its rollout. Most recently, a report, as you've heard, found almost 150 cases of harm, including 2 cases of severe harm, due to orders for everything from labs and x-rays to follow-up appointments being lost in EHR queues that weren't being checked. And I've been listening and understand you're improving, but there are still many there, and it's troubling to have a box that you have to purposely go check at the end of the day. Upon inspection, over 11,000 orders in less than a year from physicians were not acted on in a timely manner. And that's a lot of orders. I'm a physician and a patient, so I've been on both ends of orders, and it is really alarming that so many weren't seen or completed, and as a result, patients were harmed. Mr. Yackel, your patient population is generally older, sicker with more comorbidities, and so close follow-up like that matters, especially with this patient population. I'm wondering what sort of harm you have seen because of these delays.
Thanks for that question, Congresswoman. We recognize, first we know that any level of harm to veterans is unacceptable. I just wanted to make that clear. And our office is committed to the pursuit of zero preventable harm. In terms of harm, and if you can clarify your question, the OIG report about harms related to the unknown queue were accurate at that point in time. And that's found within the OIG report, if that's helpful. What I would tell you is that patient safety is a process. It's an iterative process, and when we are asked for information, it's a snapshot in time. So the information will change because as we learn more about the system, as we investigate those processes, which include the visit and the facility, doing look backs and clinical disclosure, that's when we discover harm. From the National Center for Patient Safety, we send experts to each site to help them with their initial rollout. We help monitor patient safety harm on weekly calls with them and the VISN and the OHRM or the EHRM folks and some Cerner folks as well to address that.
Since you have those meetings, those regular meetings, I was just wondering, previously the VA used the Vista system. Did you see any level of missed orders or harm even comparable to what you're seeing now with Cerner?
I cannot definitively say that in terms of the particular data point you're asking. I did ask my staff to pull some information. On average, just for joint patient safety reports from the fall of last year, there's about, on average, 800 joint patient safety reports on Vista in our system. And we only started tracking that in the fall of last year because we knew it was important to understand what was in the Vista system, what was the pattern, and then the pattern we're seeing, the emerging pattern. What I want to note is that in the Vista system, it's been on 40 years. In this new system, it's only been through 5 sites. So it's hard to compare both. They're not quite equal.
Of course, the whole idea of modernizing your electronic health record system is to have multiple systems for catching this, so things don't fall through the cracks and you're not dependent on either a paper record or somebody's memory or a sticky note in the chart, or an aging system. You know, the spokesman review covered a case where a veteran was on the verge of self-harm because of delays in his care. There were other cases about edema, which is associated with heart failure, uncontrolled diabetes. Delayed care, as you know, can lead to patient harm, and I was just wondering if you can expand on VHA's role in preventative care and even touch on minor cases, which may not be so minor, and how we can keep them from falling through the cracks. And I see I'm over time, so you can keep your answer really brief.
We have a system in place to monitor all that, and we're working with the VISN facility to pick up those cases. In fact, I have a team member working with Dr. Fisher today to explore patient harm related to the unknown queue and other queues within, as alluded to in his facility. That's kind of in brief, and I'm happy to follow up with any questions you'd like to submit, and I'll respond for the record.
Just surprised that it hasn't been done yet. Thank you. I yield back.
Thank you, Congresswoman Schreier. At this time, I'd like to recognize Congresswoman McMorris Rogers for 5 minutes.
Thank you, Mr. Chairman and Ranking Member. I appreciate you both allowing me to join this hearing today. I also want to thank you and your team for the tremendous work that you've been doing to investigate the issues around patient safety, patient harm that we've been communicating to people since the EHR launched at Mann-Grandstaff in Spokane. Mr. Case, not only has the Cerner EHR turned Mann-Grandstaff upside down, it's been a constant battle to uncover the truth from the VA. It's been frustrating to me and veterans in my community to hear the VA executives brush aside concerns that we've been raising since Go Live. And I want to thank you for documenting the safety risk in black and white. Your recent report on the unknown order queue mentions 1 incident of catastrophic patient harm and 2 incidences of major patient harm. It describes one of these situations in which a homeless veteran's follow-up appointment with a psychiatrist got lost in the unknown queue. He nearly attempted suicide, but fortunately he called the Veterans Crisis Line and they got him to a local hospital. I want to commend the Veterans Crisis Line for the life-saving work that they do, but this should never be allowed to happen. Mr. Case, when did the incident take place, and what safeguards were in place with respect to the unknown order queue then as opposed to now?
Yes, this was an incident that occurred very early in the process, starting in December of 2020, moving into January 2021. At that point, none of the mediating factors that have been put in place were in place at that time. And in fact, there was complete dependence by VA on reports from Cerner as to what was in the unknown queue.
Thank you. Dr. Ehrm and Dr. Fisher, I wanted to tell you about one of my constituents who's a victim of what unfortunately is looking like a failed EHR experiment. It took almost a year for this constituent to get a biopsy from Mann-Grandstaff, and he has aggressive cancer now. He finally got surgery earlier this year. His prospects are not good. And he's been pretty vocal about his care, and he's committed to advocating and getting others to help him. But his experience and man-grandstaff with the Cerner EHR has been absolutely inexcusable. Without revealing any names, are either of you familiar with this veteran, and why did he fall through the cracks, and what have you done to make sure that it never happens to another veteran?
First, I want to say that I'm really sad to hear that about this veteran. Certainly, nobody should suffer the consequences of a failed process and communication that occurred at the initial deployment of our new EHR. So I'm sorry to hear that. But without more details about the veteran and the circumstances, I really can't answer
Okay.
that question. I'm happy
We'll
to.
we'll get that to you.
That would be good.
Thank you. Dr. Fisher?
Yes, ma'am. That resulted from a misdirected follow-up order where the individual was supposed to be seen by urology. And thankfully, but unfortunately as well, he came back and asked whatever happened to that urology referral. And then we discovered that it went into a queue and we had not yet reviewed that case in order to intervene. So very, very unfortunate. I know this veteran pretty well, and I'm awfully sorry that this occurred to him.
Dr. Fisher, do you have the tools you need from the VA central office to ensure safety is not compromised and that all services are available in a timely fashion at man-grandstaff?
My personal opinion is that the Cerner health record needs to be improved so that all of these various mitigation strategies, which are people dependent and generally of low reliability, can be removed, and we will have a fully functional, high-performing health record. Until that's done, our employees and our veterans will be involved in these patient safety issues.
Dr. Fisher, I have one more question for you. As you know, there's been reports that inpatient services at man-grandstaff may close. I appreciated your comments during a phone call on this topic a few months ago. Can you commit today that inpatient services are not in jeopardy at man-grandstaff?
Well, I can tell you from my perspective, they are not. But I'm not the decider in issues related to services, whether they're continued, restricted, expanded. But I believe, like our employees do, that it's important to maintain inpatient services and, if possible, to expand those services in Eastern Washington.
Thank you. Thank you, everyone. I appreciate your commitment, to the commitment of the committee, in allowing me to join you today. I yield back.
Thank you, Ms. McMorris Rogers. At this time, I'd like to recognize Congressman Newhouse.
Thank you, Mr. Chairman. Appreciate you allowing me to be here with you today, as well as Ranking Member Rosendale. And thanks also to your committee for your hard work on this very important issue. And Dr. Ehrm, it's a pleasure to see you again. Just recently, as you heard earlier, Ranking Member Boston and I, we had the pleasure of visiting the VA facilities both in Richland, in my district, and in Walla Walla at the medical center there. As a guest of Mr. Keller, we were able to meet with dozens of nurses, of doctors, staff members, from schedulers to pharmacists, radiologists, you name it. We met with dozens of people there. And let me tell you, to a person, they're all committed to providing the best care possible for our veterans, and that certainly was a good thing to hear. But what we also heard from all of them, the thing that we most often heard was that the Cerner training, and these are their words, not mine, is completely ineffective. If and when employees could get into the right training session that fit their particular responsibilities and jobs, the instructors didn't know much about the system that they were trying to demonstrate. We know from the reports that we've heard through OIG that the VA's trying to been evaluating the flaws in the training for, at least a year, and ordering changes. But it doesn't seem like that those changes have made any significant improvements, at least not the folks that are on the ground trying to make this all work. So if you're continued to, or if you're committed to continuing this project, and it sounds like you are, I'm not sure everyone is, but it sounds like you are, even in the face of the the harm that we have documented that veterans have been placed in harm's way in at least over 150 instances. Is the VA prepared to scrap the entire training concept and literally start over? Could you give me a response to that?
Sure, and thank you for that question. Training has been a frustration for us. This is why we've done several things. One, at the end of April, we issued a letter of concern to Cerner with documentation where they were falling short of our expectations, and you described some of them, trainers who didn't know the subject, trainers that didn't show up, and so on. So that is a frustration for very busy medical professionals to take the time to train and to have an experience that's not good. The second thing that I did was I signed up for training. So I've gone through most of the training. I haven't done the 300, but I've done the computer-based training. They're not bad. Actually, they're pretty good. I prefer online training. But what we need to do clearly is to look at how our medical professionals and other medical personnel want to learn the system. It's more than just training. And so this is why with our new deployment strategies, we have added a good amount of change management type strategies, including ample on-the-ground support during go-live at the elbow to help personnel as they're learning the system. Because DoD, actually, that was one of their biggest lessons learned, was that having good at-the-elbow support is very helpful as people are learning the system. The other things we've done with training is that we've insisted with Cerner that they hire an independent consultant to review the training and bring us recommendations for how to do this better.
I have one more question.
Sure, I'm sorry.
And I appreciate you taking the training yourself. I was going to ask you that. But recently, in fact, just yesterday, Congresswoman Morris Rogers and I sent you a letter highlighting the difficult position that Mr. Keller and Dr. Fisher have been put in. They either have to find money to internally hire additional staff to cope with the Cerner impacts or treat fewer patients. It's one or the other. In fact, since you probably haven't had a chance to see the letter we just sent, the facilities have been forced to either significantly increase staffing to do the same amount of work or reduce the appointment volumes and manage significant backlogs. The medical centers that added permanent on-site staff were forced to do so at their own expense. The centers in our district should not have to choose between staffing up to continue safely caring for veterans and blowing a hole in their budgets, forcing painful cuts in the future. More importantly, our veterans' care should never be compromised. And then it goes on to say, whatever is ultimately decided about the fate of the program, our medical centers cannot be left behind. They've been forced into a deeply flawed system and are struggling to address the problems that our veterans face. Will you be making our centers whole because of the position that you put them in?
Me personally, from the program standpoint, it's a VA issue and VHA, and we look forward to getting that letter and answering it as completely as possible, and we'll do that together with VHA and VA leadership.
Thank you, Mr. Chairman. I'm sorry I went over my time, but I appreciate the opportunity.
Thank you, Congressman Newhouse. At this time, I'd like to go to round two and recognize myself for 5 minutes. Dr. Ehrm, I'm concerned because I learned that clinicians at the Roseburg just learned about the unknown queue. Does this reflect a continued breakdown in patient safety?
I would not expect that end users at any of the sites would necessarily be aware of the unknown queue and how to manage it. We specifically train the individuals who've been identified by each site in how to manage it and how to work with the queue. Site leadership appoint individuals, personnel, to monitor the queue. So I wouldn't necessarily expect that all of the end users would be aware of its existence.
Is it acceptable for clinicians to not know that their orders are placed?
when a physician puts in an order and it cannot be mapped to the right location, they do get a pop-up that tells them that the order cannot be filled. It is not a hard stop. The physician can override that and complete sending the order. But to your point, we are looking at reconfiguring the system so that it is a hard stop, so that orders that cannot be filled cannot be routed. But that's an issue that we have to work with VHA to do.
So you had mentioned early in your testimony, very quickly, that there are third-party patient experts that get together weekly, correct? Mm-hmm. What was the last weekly update that you received from them?
Well, because we have the hearing, we meet on Wednesday mornings, and because last week and this week the hearings were at the same time that we were supposed to meet, it was the week before last. But we do have it on our schedule for weekly.
But what was the topic?
It varies week to week, but the last time we spoke, I believe we were talking about our intention to hire individuals to complement the expertise within the Office of Health Informatics. That may have been one of the topics. I don't recall. Okay.
The last chair of this subcommittee pointed out the extreme number of workarounds being utilized to make up for a system that doesn't function in a way that supports the VA providers. Has anyone done an audit of the sheer number of workarounds being leveraged?
What we have done is we have engaged with a federally funded research and development organization called MITRE to help us evaluate some of the more high-risk and prominent workflows. The first one that we've asked them to evaluate is pharmacy. They're going to start at Columbus and take a look at the workflow and give us recommendations on how we can improve them and reduce the burden on our personnel. But we're also are asking them to also look at some of our workflows to determine how we can improve them.
It seems to me, it just seems to me that every time that we talk about an issue with the system, the VA's response is that we'll put a mitigation strategy in place, which is just another workaround. I don't think you can guarantee patient safety while asking staff to take on a massive amounts of extra work or compensate for the shortcomings of the system.
I think, you do highlight those areas that are an additional burden and require more resources, but there's other areas where the system has increased efficiencies, such as in lab, radiology, and we've heard feedback from those providers who do urgent care that the system has actually improved efficiencies and improved their work. So I think it's a mixed bag of burden versus improvements. But those areas where they are a burden, such as pharmacy, we have moved ahead with Cerner to contract for the capability enhancements that will help our medical personnel do their work more efficiently. And we have, in fact, been told by them that the top 3 that are the priority capability enhancements should be installed likely in February.
Okay. Dr. Kroviak, are you seeing this mitigation strategy actually working, particularly with lost orders?
No, actually, we see quite a few shortcomings in the mitigation processes that are currently in place. As described before, it's not a hard stop, and it requires a lot of human labor to monitor and re-enter those orders that clinicians place.
Okay. At this time, I'd like to yield back and allow Congressman Rosendale 5 minutes for questions.
Thank you very much, Mr. Chair. Mr. Case, I want to turn to your 2 reports on Cerner training. They're meticulously detailed, but I have to tell you, it's hardly a revelation that Cerner's training is ineffective. We can see that by the results. What concerns me even more is how the VA knew all along, and yet apparently took no action to hold Cerner accountable. Please walk me through pages 29 and 30 of your July 2021 report, which documents what VA officials were saying about the training privately and how they failed to evaluate it accordingly under the contract. Mr. Case, you're still muted.
Thank you, thank you.
Sure.
One of the features of our training reports is that there were multiple failures of training, and the training was simply inadequate, and it comes back again and again. Training on scheduling, training on the unknown queue, training with regard to medication management, and VA has to hold Cerner accountable for providing adequate training, and that's not been done to date. Now, that's a matter of legal analysis and otherwise, but it has to be done going forward to improve training. I've heard Dr. Ehrm just testify about steps they're attempting to take, but right now, training seems to be insufficient and continuing to be insufficient. Our recommendations have not been closed, and we've heard very little about our many recommendations on training, including a recommendation about addressing the issue with Cerner.
Thank you, Mr. Case. Dr. Ehrm, we know that the VA has used hundreds, literally, of contract modifications and change orders to enable or accommodate Cerner's deficiencies. With respect to training, has the VA ever deducted from Cerner invoice or otherwise imposed a financial penalty on Cerner for failure to meet the contract's requirements or otherwise perform satisfactorily?
We, as I stated, at the end of April, we issued a letter of concern. I have to get back to you on whether or not the contract has any financial penalties with regard to training, but I don't believe that it does.
So there's never been any financial penalty imposed on Cerner for their training or deficiencies in regards to training?
I don't think so, no.
Mr. Case, turning to the misrepresentation of the training data, it is extremely suspicious on how removing a few outliers somehow turned into excluding all the failing results. Will you please explain how your statistician tried to replicate what Dr. Ehrm's office claimed they did?
Yes, and I will note that Dr. Ehrm was not there at the time, but it was the OEHRM office. The first step our statistician took is to take the methodology provided by the training group, and he could not replicate that 89% number with the methodology they gave. He then took steps to basically start eliminating parts, the outliers. That did not get to 89%. He would eliminate other aspects. And finally, through process of elimination, he got to the point where he could get to 89% passing within 3 attempts by simply eliminating all failed training efforts. And by doing that, that's how he got to that 89%. That was not disclosed, and in fact, part of our report really addresses that the leaders of the training group were not even aware of what the consultant was doing and the data was providing. They didn't understand it.
Thank you, Mr. Case. I've a hard time believing that this was just an honest mistake. On page 32 of your July 2021 report, you quote an email between Dr. Ehrm and someone else discussing removing the outliers and what to do if your office questioned it. They also agreed in the email not to provide any explanation for removing outliers. How could Dr. Ehrm have had the discussion and simultaneously pass on the training data that Booz Allen Hamilton had modified without examining it?
That was the heart of the problem. She did not understand what Booz Allen had done. She had not gone back to review it, was not aware of it, the communications were poor, so she thought that they were eliminating simply outliers. That was not what Booz Allen had done. She then took that information and forwarded it to us as if it were an outlier removal project only, and she did not disclose that it was an outlier removal project. So there's kind of a multiple set of failures. Failure to disclose, but more fundamentally, a basic failure to understand the information she was receiving.
And finally, Mr. Case, how did you determine that Dr. Drame and Ms. Johnson did not seek to mislead your office?
Yes, we found that there was no intent, meaning there was no criminal intent here. But they were careless to the point of really recklessness in what they provided. And we did that by examining emails, by examining the data, and by multiple interviews of both of them to assess what their level of understanding was of the data. We also interviewed people at Booz Allen and, as you indicated earlier, did our own independent assessment with a statistician.
Thank you very much. Mr. Chair, I would yield back. I apologize for going over my time.
Thank you, Ranking Member Rosendale. At this time, I'd like to recognize Chairman Tucano for 5 minutes.
Thank you, Mr. Chairman. Dr. Kroviak, I'd like to hear more about the shortcomings you see with the mitigation strategies currently in place. What does VA need to do to address the patient safety risks?
So the ultimate solution will be a complete hard stop. If you are putting in an order as a clinician that can't be received by the location that needs to process it, you need to be told this is going nowhere. No bypassable flag is going to solve the problem. Ultimately, you're still going to be relying on people to monitor the queue, monitor the potential delays, and assess those risks.
Well, thank you. So when Dr. Ehrm said that there was a flag that showed up that was bypassable, that's, to you, not an acceptable mitigation.
No, the fact that it's bypassable, and we know that staff is exhausted and have limited trust in the system as is, they are going to continue to assume those orders are going to get to where they need to be.
Well, Dr. Kroviak, we know that at Roseburg, that users were unaware of the unknown queue, and Dr. Ehrm has just testified today that she would expect that the users would not. I mean, it's not a surprise, and it's not something that that we wouldn't expect them to know. But what would be the kind of mitigation we need to put in place in the situation at Roseburg? I mean, should there have been should they have been informed? I mean, VA knew. Go ahead, Doctor. Go ahead, respond.
No, I'm sorry. I completely disagree with that. As a former EHR user, if I'm putting in the order, I should be aware of the system limitations that are in place. I'm expecting that order to be carried through. And if it isn't going to be carried through, I need to know in that moment that I'm placing that order, that I need to recreate the order or notify somebody that I need this care, and for some reason the system is preventing it.
So given that VA and Cerner knew about this unknown queue, in your opinion, should the users have been informed and then trained on it and made aware that this was a defect, or made aware?
Without question, yes, it should have been a major point of the training program and information, even as mitigation strategies were put in place.
So, Dr. Ehrm, I'm troubled by your testimony that you would not have expected employees to know. Was there any attempt by VA or Cerner to inform prospective employees that were going to have to be using the system that there was an unknown queue and that they had to be aware of that?
Okay, so thank you for allowing me to clarify this. End users know that there's an unknown queue. It is incorporated in the training. In fact, in an email on September 23rd, 2021, there was a number of training materials, including tip sheets, that somebody from the previous office had sent to Man Grand staff to distribute to end users. So while they might be aware, they are not specifically trained in how to manage the queue. So I might have misspoken and it was misunderstood. During the training, staff should know or be communicated with to know that this queue exists. And in fact, if they write an order that cannot be routed, cannot be filled, they do get a pop-up that says that this order cannot be filled. As my IG colleague has said, it can be overridden. Now, my understanding is, and Ms. Johnson probably can explain it further, the council, composed of VHA personnel, had decided not to include a hard stop, but we are revisiting this issue now under the circumstances. But if Ms. Johnson wants to explain that, so.
Yep, that's correct, Dr. Ehrm. So basically, as we try to come up with strategies to decrease the number of items that are in the unknown queue, it's called a discern alert was created. And when we make decisions like that, we also go through our clinical councils for their approval. And part of their recommendation was they did not want it to be a hard stop because it would stop the work. What we did do was add an item in the drop-down that says need scheduling location. So when you get that alert and you don't have a correct location, you can pick that, and then that list, we can take that list and figure out where we need to add or to correct an order. So that was where that came from. As Dr. Ehrm mentioned, we are looking at creating that as a hard stop that will stop the work of the clinician, and so that could involve extended time in getting that order entered, but it would also decrease the number of items in the unknown queue.
Well, I have to imagine, Dr. Ehrm, that providers and physicians, people who are creating these orders, are do you think that there's a diminished trust in the system, and that adds a lot more work for the provider to have to make sure that these orders are followed through on? I mean, I'm hearing stories about that they're going through all these extra steps to verify that orders are filled.
I think, at Man Grandstaff, most especially, where the failures were most prominent, I do not blame them for not trusting the system. That deployment did not go as planned, didn't go very well. The issues around the unknown queue, though, were resolved by the time we deployed at our first site in 2022. Some people, as I've been told by the Vision 20 director, consider it a safety net for orders that could not be routed properly. And I do want to correct one statement. The difference between what the IG was reporting as the numbers in the unknown queue were for all of the sites. I was citing numbers for just Man Grandstaff in our discussions with him, and I do get those reports. And we get reports of how many additional orders end up in the queue. And so as was stated earlier, these numbers change day by day. But if appropriately handled by individuals appointed by the medical centers to review the orders on a daily basis, it shouldn't be that big of a burden.
Well, I find it, I question whether or not people reviewing these, not having a hard stop, that the orders, that people are uncertain, providers are uncertain that these orders are getting anywhere where they should go, that the system that you have in place where people have to review these orders in the unknown queue. Anyway, I've got to yield back. We've got to go vote, and thank you for your response.
Thank you, Chairman Takano. At this time, I'd like to recognize Congressman Bost.
Thank you, Chairman. I'll try to make this brief as possible. First off, Dr. Ehrm, if you said in your statement a while ago that radiology, urgent care, and labs are where we see benefit. After my going and seeing and visiting with the staff and employees and contractors at Richland and Walla Walla, the only one that said positive things was lab. I didn't hear any positive from the other. And as we're doing cost-benefit analysis, how many millions of dollars do we have to keep spending to finally get a cost-benefit analysis to where the staff realizes that we actually have a benefit? I mean,
so with regard to my comment about urgent care, this came from Columbus. They were actually very pleased with the system and felt that it helped them see patients quicker. That's the feedback I got there. Radiology, I based that on the objective measures that I track through a part of the system called Lights On. Their radiology turnaround times at the sites, all 5 sites, are really good. So that's where I get my data from.
Well, let me tell you, I got my data from going to actually talking to them. And the concern that I have is, you know, as we're trying to be the oversight on this, and I feel like the administration is ignoring a lot of things that your staff, and the best example of that, I guess, during this whole process was the fact whenever we did a survey of how employees and contractors feel about the system and everything like that, and when those numbers came back, you know, I'm in a business, and all of us on this dais are on a business where we try to get a majority of the people to be comfortable with what we're doing and actually be able to show them where things are positive. You're doing a poor job of that. Your employees, if I got the numbers back on a poll in an election, the way you got the numbers back on how they feel this is doing, you better, as a politician, I'd quit. We have to get this straightened out. And how do you explain, because we're liable, one, most importantly to our veterans for their safety, 2, to the taxpayer, specifically to the taxpayer and the long-term benefits, and we just keep falling down with this system. And I don't know what we've got to do to get it straightened out. And if we don't get it straightened out, and I'm afraid we're going to come back here. I know we're scheduled for votes. We're going to come back here in a month and a week. The one thing I can guarantee on in my briefing as the ranking member is how being told by my staff how bad this is happening. And we keep changing people who are looking into it only to find out it's just getting worse. And we've got to be responsible people. I appreciate you coming in today, and I appreciate the opportunity to stay here through this hearing. Chairman, thank you for putting it on. I'm afraid I would love to say that this is all going to straighten out, but I don't see it right now. But we'll be continuing to work forward with legislation as well as oversight to do our jobs and try to make sure that it is straightened out. And with that, I yield back.
We will recess briefly to vote. I ask members to return as soon as they vote on the second vote. This hearing is in recess, subject to the call of the chair.
there's like a whisper spot.
I've got a, we told Ed Laker that I had this to do, and then when I have, what's the real demand is I have to be able to go vote. Yes. That's all. And then I can cast my vote for my way right now. So I'm not planning to speak or.
Are the platform hosts ready to begin?
Yes.
Mr. Chairman, are you ready to begin?
Yes.
Please give a 5-second countdown.
5, 4, 3, 2, 1. This hearing will come to order. And then I could just roll right in. I'd like to recognize myself for 5 minutes. Dr. Fisher.
Yes, sir.
The OIG report indicates that the unknown queue issue was first identified within 4 days of your facility going live with the Cerner system. Is that correct?
That is correct.
And after it was identified, how long did it take OEHRM to address this issue with you and your staff?
That occurred in June of 2021, and that was following the arrival of the patient safety team deployed from the National Center for Patient Safety. We had many patient safety concerns throughout the year. And finally, we realized as a facility, we really needed the assistance of patient safety experts. And so they came in June, and in June, we received our first brief on the unknown queue and several other queues. And that's been an evolution, and more queue discoveries has occurred in the meantime.
To be clear, when did you learn about it?
June of 2021.
Okay. When did your facility receive the first report from Cerner with the content of the orders that were sitting in the unknown queue?
I believe the first related to imaging orders. And there was a subset of experts in radiology that were communicating with Cerner to get these reports generated. And they were addressing those kind of as best as they could until such time we got feedback from Cerner. These folks got feedback that we were doing a good job, that the queue is reducing in number, and to just continue to do what we were doing. We had no idea, however, that this involves several queues and not just imaging queues. And that recognition occurred over months, and then finally culminated in an actual comprehensive brief on the various queues and having some formal system to review those through lookbacks and to mitigate and intervene when required.
What is your perspective on where the queue issue stands today?
In my opinion, the existence of 17 queues, 15 queues, 9 queues, I think it is an ongoing risk to patient safety to have the existence of queues. The health record should stop orders that cannot be completed at the entry point, period. The idea that we have to surveil 9 or 10 queues and they continue to increase in number, I don't think is satisfactory.
Thank you.
Sure.
Dr. Yackel, I have heard that there are other queues in the Cerner system. Specifically, we have heard that there are questions with the needs scheduling queue and that staff are having trouble accessing it. Has anyone done any evaluation of those queues to determine if there was risk to further delay in care of risks to patient safety? If so, what did you find?
Thanks for the question. I appreciate the previous speaker talking about the support of National Center for Patient Safety. We had a team on the ground since May of last year, and we continue virtual support today. I've personally visited twice to talk to the staff there. In terms of your question, sir, we have a team that's been continuously monitoring joint patient safety reporting since the inception of the program. And we are, in particular, we're looking at the queues and highlighting those, exploring with the facility what those queues are. Can you reiterate for me the particular queue you're referencing, please?
Well, I was just the unknown queue and any other queues that may be causing confusion.
Okay. So over a period of time, as Dr. Fisher indicated, as we've learned more about the system, we've organized all the joint patient safety reports into domains. Those current domains are ambulatory care, data migration, identity, medication administration, orders, pharmacy, referrals and consults, roles, behavioral health, and suicide risk, and unspecified. This is how we take a bunch of joint patient safety reports and put them into these, we call them domains or buckets, so that we can then look at them across the system to determine what's going on, what actions can we take, how do we work with other entities like the Ehrm office, the VISN, the facility.
Okay. Mr. Case, is the OIG monitoring any other queues?
We've heard concerns about the needs scheduling queue, that there's limited visibility into that by clinicians and others. And we've also heard concerns about queues involving pharmacy and lab. We don't have any current projects looking at those now, but we're aware of them. And we do understand that VA is doing some work to try to determine what the issues are, how they can be remediated, and working with Cerner or even eliminating those queues.
Okay. With that, I'd like to recognize Mr. Rosendale, Ranking Member, for 5 minutes.
Thank you, Mr. Chair. Dr. Ehrm, the Spokane Spokesman Review published an article on July 19th about a list of over 180 Cerner incidents of downtime, degradations, or outages since September. You testified last week to the Senate Veteran Committee that you had not seen that list. The VA press secretary is quoted in the article as saying VA officials could not verify the incidents listed in the spreadsheet because they do not recognize the terminology that's used. As the person who's responsible for this program, do you maintain that you were not one of the VA officials who reviewed the spreadsheet, or would you like to change your testimony at this time?
I don't think I need to change my testimony. This document came from the media, and our experts took a look at it, didn't recognize things that were on it, and worked with our public affairs to provide a response. I didn't personally review it and go through it. We did go through the document that was sent to us by the SVAC last week. and did provide a response to the committee this week on the difference between the document we received from the SVAC and our records.
Dr. Dearm, every time the VA has given account of the Cerner downtime incidents, it's been radically different, and the numbers have been much lower than what we hear from the medical centers themselves. I actually have had you contradicted by your own staff. Don't shake your head no to me. I hope you were just getting hair out of your eye.
I was getting hair out.
Because I have had
Apologize.
your staff contradict you right here in front of me on those numbers. I'm not interested in playing games with definitions. Do you dispute that some element of the Cerner EHR has been unavailable or unusable consistently multiple times per week for the last 10 months?
Congressman, this has been a frustration for us. I do not dispute it. We are aware of the degradations. There have been 49 degradations and 24 outages. We have reported all the big ones to all of our committees, and this is a frustration we've had with Cerner. We are disappointed in the capacity, reliability, and stability of the system, and that was probably one of the biggest reasons why we delayed going to bigger sites, because then this would affect our end users. I have been an end user. I understand the disruption that any degradation or outage has on the ability to perform work and provide care to our veterans. So I do not dispute it in the least.
So VA informed us on June the 9th that Cerner and Oracle were installing an update to permanently resolve the downtime related to the Oracle databases. Has that been successful? Is the system still experiencing downtime? And if so, what's causing it?
You were accurately describing that there was a patch performed by Oracle engineers to resolve bugs that were in the system. So from that particular issue, we have not experienced issues, but there have been additional and other issues, including as late as yesterday, Cerner implemented a patch on a Tuesday afternoon that we were not aware of that caused downtime. That's an issue that frustrates us because we have told them repeatedly that we must know before you do anything like that to the system. So I think that that's a really good question to ask the next panel.
So you testified in our last hearing, and VA separately informed the committee staff that Cerner has failed to meet the service level agreement in the contract. In addition to sending Cerner a letter and withholding $156,750, what financial penalties have you imposed on Cerner?
Those are the financial penalties that were assessed, because that's that is in the contract that we can assess for based on the amount of time that the system is down. We are reviewing that so we can determine performance metrics with regard to the system that we can impose when we modify the contract.
If we continue to modify the contract with change orders and these contract modifications, how in the world are you ever going to hold them responsible for the delivery of their service?
The way that the work is done on this fixed price contract is through task orders and modifications to the contract. That's how the work gets done, especially those things that are above and beyond the base of the contract.
I yield back, Mr. Chair.
Thank you. I now recognize Chairman Takano for 5 minutes.
Thank you, Mr. Chairman. The committee continues to hear from staff and leadership in Spokane and all the other facilities using the system regarding their dissatisfaction with the new EHR system. Whether it is the training provided or the difficulty it creates in providing care to patients, the common theme is that there are issues and the staff working with the new system don't feel their concerns are being taken seriously. So, Dr. Ehrm, what are you doing personally to improve VA's ability to manage the Cerner contract?
Thank you for that question. And I I don't think it's fair to say that we don't take their concerns seriously. We do hear them. One of the things that I have done since I've come on board is participate in all town halls with staff so that we can hear what their concerns are. These are done pre-deployment. Columbus held 2 60-day review town halls that unfortunately I wasn't invited to until the last minute, but I ensured that we had staff there to listen to those town halls. I was sent the PowerPoints with the list of concerns, so we do take all of these very seriously, and we are creating a governance structure within VA with the program in order to better review and validate and prioritize recommendations from the field.
Well, okay. Well, when can we expect to see real action being taken to address the safety issues that we've raised here?
Well, we've taken real action when it comes to our deployment strategies. So, for example, as Dr. Yackel had mentioned earlier, we have held educational sessions pre-deployment. We've done workshops. We've held exercises. During deployment, we provide ample at-the-elbow support as well as patient safety team that goes to the deployment site to rapidly triage and review all patient safety reports as well as trouble tickets. So from a deployment standpoint, we have really improved what we've done, including in January, I led the development of a very detailed readiness for deployment checklist that we use and we update since we're an initial operating capability to ensure that we've done all the things that we need to do to ensure a successful deployment.
What I'm not hearing, Dr. Ehrm, is any intention to fix the system. I mean, you're referring to the training and the implementation. We continue to see task orders awarded for deployment to new VISNs, as opposed to task orders to fix the existing system. That's what I'm not hearing from you. I mean, I've just heard that $500 million just awarded in a task order for deployment activities in Northwest Indiana and Chicago. So,
thank you.
Where am I hearing about the task order to fix this unknown queue and all that
Sure,
stuff?
sure. Well, the unknown queue is a design of the system, and we have put measures in place to use the queue the way that it is. There was a configuration change to the locations to reduce the risk that somebody could send an order to the wrong location. With regard to some of the other issues that need to be addressed, on July 6th, we entered into a contract with Cerner for the pharmacy enhancements. They are right now determining, the timeline and the roadmap to getting all of those enhancements in place. We have also have begun the process and hope to have in short order more prominent behavioral health flags in the system. Right now, the flags are only prominent in PowerChart and FirstNet, which is the clinician-facing parts of the system. But in 2 to 4 months, we anticipate having more prominent flags for the revenue cycle, FarmNet, and RadNet. And so we are proceeding in a number of these changes that our healthcare providers need and want in order to do their work.
So maybe it was a system design before, but it doesn't work for VA, it doesn't seem to me. Are you saying that clinicians for the next 10 years are just going to have to accept workarounds to this fundamental system design?
The system is used in all their commercial customers, and this may be a question you want to ask them, since I don't necessarily agree with this design or find it to be the best design, but that's the way it was designed, and we have put in changes and processes in place that should have been in place at Mayo Grandstaff, so that our sites can use the unknown queue as it was meant to be used. It's a safety net for orders that cannot be routed to the right place. They end up in that queue so they can be reviewed and corrected. Now, since man-grant-staff, the number of orders that end up in the unknown queue at each one of the sites are far lower than the numbers that had previously been cited by others here. There was last week new orders going into the unknown queue. There was one day, Tuesday last week, there were 0 for man-grant-staff, 2 for the next day. So we've really, through these processes that we put in place, reduced the number of orders that end up in the unknown queue.
Well, still, I am envisioning and imagining a whole VA workforce out there that is used to hard stops on Vista. They get a hard stop. They can't. These orders cannot go through, is what I understand. So the unknown queues don't exist under Vista, and I'm not saying we need to continue with Vista, but I'm also befuddled as to how the private sector can put up with this sort of unknown queue and the burden it puts on their workforce. But I intend to ask these questions in the next.
Sure. May I have Ms. Johnson explain Vista, because Vista has lost thousands of orders as well. So I'd like her to explain.
I'm over time. I've got to
Sure.
get back.
Dr. Ehrm, and I'd like to recognize myself for 5 minutes. Dr. Ehrm, you can take this for the record if needed, but can you provide the dates when pop-ups became visible to clinicians sending orders?
Actually, yes, I'd like to take that back. I have some information here, but I think taking that back to get you a correct answer.
Okay. And at this time, I will yield and recognize Ranking Member Rosendale for 5 minutes.
Thank you, Mr. Chair. We're going to go into the pharmacy issues again. Dr. Ehrm, I'm glad the VA finally directed Cerner to fix the pharmacy problems on July the 6th, but it seems totally unreasonable that those additional modifications to the pharmacy software would cost an additional $68 million, which is more than the original $40 million that the VA originally agreed to pay for all of the pharmacy development. I'm referring to, and you just received it, to Task Order 31 under the Cerner contract that was signed on September the 3rd, 2020, and Modification 2 to the Task Order 52 that was signed on July the 6th, 2022. Again, these are some of the exact change orders and contract modifications that I referred to earlier that continue to enrich Cerner for poor performance. Why does fixing the problems cost $68 million when the whole effort was supposed to cost $40 million?
Sorry. Mr. Rosendale, the issue of the pharmacy enhancements are items that are above and beyond the baseline of the contract. These enhancements are tailored to the way VA wants to do its healthcare, and so it is different than the way the commercial sector does pharmacy work. And therefore, there's an additional cost above and beyond the contract. This would not be technically considered a fix. It is a change or an enhancement to the system.
So this goes back again to the sole source contract where Cerner was able to secure this, and yet we continue to see modifications and change orders and modifications and change orders as they go along, as they determine and discover what work the VA truly needs them to take care of, and they are making billions of dollars off of it while our veterans are suffering. They're not getting better service. Every time we invest another $68 million or $100 million, the veterans aren't getting better service as a result of that. We still are seeing all of these problems take place. And it goes back to my sole argument. We continue to see these problems, and Cerner continues to make millions and millions and hundreds of millions of dollars, and nothing is being addressed. Dr. Ehrm, the purpose of the $40 million was, and to quote you, accommodate the VA-specific pharmacy requirements, end quote. Yet in our previous hearing, you characterized the new MMR fix as tailoring the Cerner product to a VA requirement. How did the VA overlook this requirement, and why are you paying for it again?
I wasn't here during the initial, I don't know if Ms. Johnson can answer that question better.
Yeah, and I don't know the specifics of the requirement that was put forth for the original contract, but I can tell you that the requirement for pharmacy is much different than it is in the commercial sector. And I'm not sure that's the specifics of how the VA handles medication retail, which would be like you're going to your CVS or your Walgreens, was clearly articulated in the original requirements.
To use Mr. Chair's word, this just befuddles me. It truly does, that we have all of the experts in the field sitting here, and you didn't describe to Cerner what was needed, and Cerner, as an expert in the field, didn't understand what you needed, and meanwhile, the taxpayers are paying billions of dollars for a piece of junk, and our veterans' lives are being risked. Dr. Ehrm, Task Order 31 for the pharmacy development work stipulated that Cerner would demonstrate the functionality that it was developing to the VA, and the VA would, quote, provide feedback and approval that the development completed to date and remaining planned functionality meets VA needs, end quote. Cerner delivered the first code in January of 2021, and they're continuing to deliver code. That means whoever accepted Cerner's pharmacy software was unaware of what was happening at Mann Grandstaff, or they completely ignored it. Either way, you have already been paying for software development that failed to meet VA's actual needs. Do you agree that VA should not be doing that?
I think that's probably more of a question for Cerner, since I was not here during that time. I didn't personally put forward those requirements, and I don't.
But you're requesting the continued payment.
I'm requesting payment for enhancements that are above and beyond the base of the product. That's how the contract was set up.
Mr. Chair, I'm at my time, so I would yield back.
Thank you, Ranking Member Rosendale. At this time, I'd like to recognize Chairman Takano for 5 minutes.
Thank you, Chairman Mervan. Dr. Ehrm, what part do contractors in the Program Management Office play in the review and approval of deliverables from Oracle Cerner?
Let me get you an answer back on that, a more complete answer.
Thank you. Are you satisfied with the performance of the EHRM Program Management Office contract, the contract?
Are you talking about the Booz Allen contract? I'm not sure I'm following.
Yes.
Yeah, I think so.
Well, Booz Allen was involved in, as we just heard today, they were involved in some questionable reportage on the performance of employees on the tests. And you're satisfied with Booz Allen's performance?
I'm not satisfied with that performance, no.
It seems to be a pretty big part of, I mean, this whole training issue was a pretty big deal. Well, but overall, you're satisfied with them, notwithstanding what that particular aspect of their performance.
Right. I would say that in my short time at VA, I have not uncovered issues such as that. I've, overall have been okay with their performance.
Well, I mean, well, let me go on. Well, VA is currently working on an award, on awarding the Program Management Office contract for, VA is currently working on awarding the Program Management Office contract for OEHRM. I've heard several accounts of scope creep and redundancy between the Cerner vehicle and the Program Management Office contract. And my staff has been watching this process closely to ensure that VA is doing their part to deconflict this effort. Further, the contract vehicle that VA uses to award this contract does not give me a great deal of confidence that VA is doing enough to encourage competition. So, Dr. Ehrm, while I realize that you are not the contracting officer for this, you are the program executive and an integral part to defining requirements. Are you engaged in the competition of this contract?
Not me personally, no. We have staff that are expert in this. Our program management office is involved with developing the requirements and putting out the contract with our contracting official in the department.
Well, what contributions did you or your staff make to deconflict the work of the program management office, the work that the PMO will be doing with the work that Oracle Cerner is tasked to do?
I'll get you an answer. I'll bring an answer back for that.
Thank you. Has the contract office requested information on past performance of the incumbent contractor?
Again, I would have to bring that back to you.
Well, thank you. Well, you know, while patient safety is my #1 concern for this program, a recent briefing on the life cycle cost estimate for EHRM modernization is also troubling. We've had a hearing on unreliable cost estimates with EHRM this Congress, which led directly to Chairman Mervan's new law requiring increased cost transparency for the program, which Ranking Member Boss and I co-sponsored. I know this report was conducted prior to the passage of this law, so I'll be interested to see if the final results capture the true cost of the program. So, Dr. Ehrm, when can we expect to see the final version of the life cycle cost estimate?
We're being told we can anticipate it sometime in August.
Okay, thank you. I'm concerned about this potentially large cost increase and will request in advance a detailed briefing for my committee staff to discuss drivers of this program. You can expect increased scrutiny over any attempts by VA to continue go-lives without addressing the current issues at Spokane and other medical centers where Cerner has been deployed. I know that Chairman Mervan has previously asked for deep dive briefings into OIT budget at VA. These have been extremely helpful to the work of the committee, and I will also request that we get the same from the EHRM program. The committee needs to hear directly from sites where the Cerner system has been deployed, and we need an extensive briefing on all patient safety issues, and we need briefings on cost and schedule for the Cerner contract from the program and contract office staff. Dr. Ehrm, will you commit to coordinating these briefings with committee staff and ensure that they are provided by the appropriate groups within VA?
Absolutely, and we have committed to being as transparent as we need to be and providing any information that you ask for plus. So
I appreciate that, and I appreciate that answer. I yield back, Mr. Chairman.
With there being no further questions, the first panel is excused. Thank you for your participation today. We will take a brief recess to reset the witness table. General Manager of Oracle Cerner Government Services. Mr. Cecilia, you are recognized for 5 minutes.
Chairman Mervan, Ranking Member Rosendale, and members of the committee, thank you for the opportunity to be here today. I'm pleased to be joined by my new colleague, Pat Sargent, Senior Vice President of Oracle Cerner Government Services. I realize this testimony is my last opportunity to make a first impression, so I intend to be completely candid and transparent about where we are and where we are going and what changes Oracle can bring to the federal EHR. Let me start by saying that the VA EHRM rollout is clearly behind schedule, below expectations, and over budget. But let me also say that with Oracle's acquisition of Cerner, we believe we can get back on track, exceed expectations, and keep program costs in line. We hope to have the committee's support over the next 9 months to demonstrate that we can deliver and then earn your trust and long-term support so this program can benefit all our nation's veterans. As you know, Oracle acquired Cerner 7 weeks ago. After reviewing all the engineering issues, I have concluded that there is nothing here that can't be materially improved in reasonably short order. Oracle brings an order of magnitude more resources and a substantially larger engineering team than Cerner alone. We have already shifted Oracle's top talent to working on this program as the company's combined #1 priority. We set up a war room led by a team of Oracle's most senior engineers, and they already are making a number of improvements. Oracle's goals are twofold and in this priority order. First, to ensure patient safety above and beyond anything else, and second, to deliver the most modern, intuitive, performant, and secure EHR in the world. As we focus on these goals, we know there are undeniable issues that need to be addressed. First, regarding performance. I announced last week that with the VA and DoD's approval, we intend to move the Cerner application to a state-of-the-art, federally certified cloud data center within the next 6 to 9 months, which will deliver far better performance and stability for the end user. This move will be completed at Oracle's expense. Next, we are going to improve the EHR's design so that the processes and workflows work better for end users. A case in point is the unknown queue. I've read the Inspector General's report, and I agree with its conclusions regarding the technology and training. Our plan here is threefold. First, we have made the drop-downs more intuitive by filtering and providing only relevant choices. Second, we will automate on the front end so far fewer records get routed to the queue in the first place. And third, we will embed notification alerts for practitioners so that tasks sent to the queue are never forgotten. We intend to address these issues within weeks, again, at our expense. Third, issues where functionality is not yet developed or not meeting user expectations, like pharmacy. In addition to fixing the existing issues, in parallel, we're going to start over on the pharmacy module and re-engineer it as a showpiece of what is to come. We believe that we can have a beta version of the new pharmacy module built and delivered within the next 6 to 9 months. Another issue that we intend to do better at is transparency. Within weeks, we will be providing an electronic dashboard which will catalog the items on our to-do list with full information of expected dates of completion and progress along the way. Cost has already come up today, and I would like to make clear that Oracle intends to deliver the EHR system across the entire VA for the amounts contemplated in the current contract. That includes our intention to move to the new data center, and that includes fixes or upgrades for things like the unknown queue or referrals. Lastly, I want to discuss a little bit about the future. Oracle plans to invest substantial resources to rewrite the entire Cerner EHR as a modern, stateless web application. This means it will have everything you expect from a modern app: an intuitive user interface, voice recognition, and no device dependence. Utilizing built-in analytics, providers will be able to view a patient's longitudinal record from enlistment through retirement and full-time end-of-life care. In addition, AI and machine learning on top of the entire DoD VA population will yield rich insights into care plans, preventative maintenance, and more. Now, I know it's hard to imagine now with all the present concerns, but this is the future we intend to provide. And Oracle has a track record of delivering. Our commitment to you is to deliver this additional functionality as an upgrade to the current system at no extra cost to the government. In conclusion, Oracle is energetically accepting of this challenge, and we believe that we can deliver. Thank you.
Thank you, Mr. Cecilia. I'd like to note that we have asked the Office of Inspector General to remain available for questions during this panel. I now recognize myself for 5 minutes. Mr. Sargent. VA and Oracle Cerner seem to be painting the unknown queue as a safety feature for the system meant to catch orders that were sent to non-existent locations. Is that accurate?
Yes, sir, that's correct.
When did VA first authorize the use of the unknown queue at Man Grandstaff?
The date that I have as relates to VA discussions and a working group was agreed to in January of 2020. As you know, I just got here and it was pretty difficult to go back and find details, but the details I have before me says that there was a discussion on in around January of 2020 that this would be a system that we would use within the VA.
Why do you believe it took 15 months after the go live for the facility to get the ability to monitor the queue themselves?
The information that I have before me looks as though I have is that the EHR in the go live with regards to Man Grandstaff, that's in September, on the 30th of September, they manually started moving information into the new system. So in my estimation, they had, Man Grandstaff and everybody had an understanding that the unknown queue was a place that we need to work on. But more importantly, on the 24th of October is when they went live at Man Grandstaff, as discussed earlier. And then we had, as discussed by Mr. Fisher, it was the 28th of October that I have that radiology department at Man Grandstaff placed their first ticket within the Oracle system based on a unknown queue issue.
So, Mr. Cecilia and Mr. Sargent, given what we know now, do you think the unknown queue works for VA?
I do not. I think we will deliver. Well, I think we will deliver new functionality next week for further testing by VHA, as I just said, which will largely prevent orders from showing up in the unknown queue in the first place. If they do show up, there will be an alert. That alert will never surrender until the order is eventually assigned to the right location. I think Dr. Fisher said it best. In my opinion, the unknown queue should not exist. There should never be a situation where an order can be sent, can be left to a queue that requires humans to process it. Now, what we're doing to address that is to actually turn the computers loose to process that, to make sure that they're not forgotten and to alert the humans. However, we will continue to work with VHA and the Patient Safety Council and others to design the feature in such a way that the unknown queue no longer becomes a, quote, feature in the system or the way the system works at all.
Given what we've heard, that the unknown queue was first identified at Man Grandstaff 4 days after go live in October of 2020, Cerner didn't train the people at the facility to start sending the report until February of 2021, and didn't get to the personnel at the facility, get the personnel at the facility the ability to pull the report themselves until March of 2022. In your opinion, if the unknown queue was planned for the intentional, does this timeline make sense?
No, it doesn't. I mean, candidly speaking, and I'm noticing there's dates and times that are being discussed that I don't have, clear line of sight towards. So to answer just simply, no, it's not. The moment that we find that there is a defect or a misunderstanding of a programmed enhancement that we have the obligation to put forth the training to make sure that the issue could be mitigated and has no impact on patients' safety.
So just as a point of emphasis, that given the timeline, there's no way this was planned for or intentional?
To my knowledge, no. And one concern I have is that as I look at the training that took place, as I understand, talking about history now, that there was significant changes still going on at the time that we were going live at Man Grandstaff. So our ability to train specifically for all of the requirements that we were going to use at Grandstaff candidly did not take place. However, we've learned from that. And at this point, before we go live, as Dr. Ehrm mentioned, with the go live checklist, we're moving forward to ensure that every user and that the leadership of the facilities has a keen understanding of how to make it, how to interact with it to deliver patient care in a very safe and efficient manner.
If I may, I've already have exercised my time, but I have one more. From the contractor perspective, where was the breakdown with training requirements and the task orders?
Can you hear me? Okay, got you. So right now, we have, as it relates to training, we get requirements from the VA, and our training leadership work directly with the VA to make sure that that we understand the requirements and that it's delivered in the manner by which the VA expects. We know after Grandstaff, we had an independent audit of our training. And there was over 3,000 substantive changes made to the training to make sure that it is aligned with the way that the workflows within each facility is taking place. So, and essentially, we have learned from our issues at Grandstaff, and we have made in-stride changes to ensure that the training is reflective of the way that the care is delivered within and across the hospitals.
And with that, I yield, and I recognize Mr. Rosendale, Ranking Member, for 5 minutes.
Thank you very much, Mr. Chair. The rotation of a new vendor or participation of a new vendor, which requires new witnesses, is disappointing and complicates our work. However, I can see why Oracle purchased Cerner, as it's a very lucrative investment. Mr. Cecilio, I believe you heard my questions to Dr. Ehrm about the pharmacy development work. Were you aware that the VA and Cerner had agreed in 2020 to a $40 million to tailor the pharmacy software to the VA's needs?
I was aware that the VA was working with Cerner to tailor the pharmacy software for their needs. I was not aware of the dollar amount.
Okay, we just heard a lot of testimony from you claiming that Oracle is bigger and better and will deliver a state-of-the-art EHR. These are my words, not yours. I'm not quoting, but basically summarizing. And at no additional cost to the taxpayer. The additional $68 million was agreed upon on July the 6th, which was after Oracle acquired Cerner. How did the total price tag for pharmacy development go up total to $108 million?
My understanding, and I'll ask my colleague to add additional color as well, is that an existing task order was de-obligated by that same amount of $68 million, so it was not a net increase in total cost. As we look forward in the cost compression, I think the opportunities for compressing costs in this contract are very rich and in two areas.
Explain compressing cost, if you would, for me.
The first is, we're going to, as I mentioned in my opening statement, we're going to move this, of course, with the DoD and VA's approval, we plan to move the entire system to a new modern state-of-the-art cloud technology data center. In my experience, technology should become less expensive to operate over time, not more expensive to operate over time. Problem with the current cost estimates that I see is that they assume the technology stands still. The technology standing still would not be a good idea for many reasons. Number one, it will still be very expensive, brittle, and difficult to predict cost around. And number two, the government will not get the benefits of all the new features and functions that we're developing for the government worldwide, for the government wide in these federally certified data centers. The other area is in training. As we think about, and the training issue has come up in the first panel many times, and I agree, it's not good. I'm not here to make an excuse. I'm not here to deflect. I'm here to tell you that a system should require as little training as possible Now, medical systems have a few exceptions in that there are compliance things, there are HIPAA regulations and things that require a minimal amount of training. But when I look at the amount of training that's required to learn the system, to me, it alarms me. It shouldn't be that complicated, whether it's consumer-based training, computer-based training, or in-person training. We shouldn't have to spend hours or weeks learning how to use the system. A modern stateless system should be intuitive and easy to use. Just like the systems we built and donated to HHS, this is being Oracle, not Cerner, built and donated to HHS during the period of COVID, which require no training for end users to use, either patients or providers.
That's fine, and we have many discussions about the training and the amount of workforce that has tied up during that period. I want to get back to this compressed investment again. So what we're talking about is we're still going to have all these additional costs associated with developing software that already has been committed to, and costs that we haven't even completely identified yet. But what you're trying to tell us is it may cost a little bit more now, but in the long run, you're going to save money?
Absolutely. There's no
So
question.
excuse me for cutting you off, but this is the federal government, and I've been looking at it from the outside for a lot more years than I've been looking at it from the inside, and I'm tired of hearing that, and so is everyone across the country. Pay me now, we're going to save you money later. That really, really doesn't sell well on Main Street, Montana, I want to tell you, sir. So,
I understand that. We plan.
on June 27th, we sent the VA a letter enclosing a spreadsheet of 36 key issues with EHR that must be resolved. My staff provided a copy to your office. The unknown queue and the 7 pharmacy issues are included. Do you have solutions to any of those 36 issues?
We plan to roll out the functionality to VHA for testing on August 1st for further improvements to the unknown queue. As Dr. Ehrm said as well, we plan to roll out the first 3, which are the major issues associated with the pharmacy issue, in February.
Thank you. Mr. Chair, I yield back.
Thank you, Mr. Rosendale. At this time, I'd like to recognize Chairman Takano for 5 minutes.
Thank you. Mr. Cecilia, training and change management have been major topics of our oversight to date. It seems that no matter how much we talk about it, staff doesn't feel, meaning staff on the front lines, doesn't feel like it's improving. We're already hearing from frontline staff who are just beginning their journey that the training is not specific to their position, is not comprehensive, and does not meet their needs. So my question to you is, can you please talk about what Oracle Cerner has done so far to improve training and what is in the works?
As Dr. Ehrm mentioned earlier, we at the VA's request and at our expense, we've hired an outside consultant to come in to review the overall training program, to review the delivery of the training, identify gaps, and identify areas where it can be improved. As I'll say what I said again, though, I think the ultimate goal here is to eliminate most of the training. Systems should be intuitive to use. Nobody has to teach any of us how to go to a website and order something to be delivered to our house in a matter of days or minutes. I don't think that just because EHR systems are complex, that it means that they have to require large amounts of training, and we've demonstrated that in many of our businesses, many of our clinical businesses, including our clinical trials business today, where we have one of, if not the largest clinical trials and pharmacovigilance businesses today. It requires very little training for epidemiologists and practitioners at major pharmas throughout the world. I believe we could do the same thing with the current EHR system. It does require us to rewrite this into a modern stateless web application, which we will do.
Well, thank you. Is there anything, well, I hear what you're saying about the training, and I would think that that is possible to have an intuitive system that requires little training, but what recommendation would you make for VA to improve the training for the current situation?
Thank you for the question. Having led a hospital, Darnell Army Medical Center, and various hospitals across the DOD, we have to be able to make sure the person is not just qualified but proficient. Currently, there are proficiency checks, computer-based, with the actual requirements that the individual end user is going to have to do and perform. Right now, as I said before, we've already updated almost 3,000 instances of change to make sure it's relevant to the duties that they're having to perform within the hospital at this particular moment. We've had to, in many occasions, based on COVID, we had to change the dynamics of in-person training, as an example, and then do the computer-based training or do it via virtual delivery. So we are working with the VA to solidify the actual requirements that they would like us to be able to do, but also to make sure that we have an outside agency to come in to make sure that we are doing it in the most professional manner possible.
Well, I understand that Oracle Cerner has formally proposed to VA some comprehensive reform of that training, of the training program. Can you tell me how receptive VA is to your recommendations?
I would just tell you that we haven't gotten approval to move on those particular recommendations. And we're, like we said, we're contracted with a third party who's going to look at those recommendations and try to determine whether or not they're still valid and to approve upon them. And so we have this should be planned before September the 30th, and that we will work with the VA to try to incorporate those before we move forward with our training in the January timeframe.
Well, again, I wanted to say I appreciate Mr. Cecilia's sentiment that the system should be intuitive, but I know there's going to be a time gap for that development to happen for an intuitive system. In the meantime, we're going to need improved training for the employees to use the system. So what is the current state of change management activities to this end, and how are you measuring the improvement?
We survey our end users, and we've seen an increase in the level of adoption across the board. To your point, change management within our process starts about 18 months in advance of going live. In a high reliability organization, leadership matters, and I think that's what I've been hearing across the hearing earlier. We got to work with not just the VA, but the VISNs, with the medical center directors, all the way down to our colleagues, our associates who are working at the elbow with our VA medical staff and administrative staff to make sure that they are capable of being able to expedite, but also that we are economizing and making great utilization of a physician's time inside of a facility, not to impact the productivity that was mentioned earlier. We've seen that the productivity, while it goes down, it does come back up relatively soon after after go live.
All right, thank you. I yield back, Mr. Chairman.
I now recognize myself for 5 minutes. Oh, I am so very sorry. I now recognize Ms. Schreier for 5 minutes. Congresswoman Schreier.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today. I am really concerned about further rollouts of the electronic health record modernization program in light of the Inspector General report. And this is not the first problem we've seen. I have been on the VA about long phone call times, difficulty getting appointments, lost communications, and it's putting our patients, and these are veterans, at really an unconscionable risk. I'm a doctor, and I used Cerner as a practicing physician in the commercial market, and I don't know what the expenses were there. I know the expenses with the VA are astronomical, but I'm really supportive about modernizing our health records to improve patient care. That's the whole idea, is so things don't get lost, and that anybody who looks at that chart remembers what comes next. And what we're seeing in this report is that the rollout is very likely doing the opposite. There were 150 cases of patient harm found in this most recent report. 2 major cases of harm. 1 might ultimately result in a fatality. This is devastating. And as a doctor, really terrifying, horrifying. Upon inspection, 11,000 orders were not acted on. That means doctors saw the patient, saw an issue, asked for follow-up, made an order, and the patient didn't get that care. Mr. Cecilia, has this problem been fixed at the facilities in Eastern Washington?
I believe that with the additional functionality that we will deliver next week for testing, the unknown queue situation will hopefully be eradicated as we go forward. Obviously, we need the experts who are clinically facing to sign off on that. But to your point, we're not going to advocate rolling out anything in the future that isn't safe and isn't deemed to be safe. We'll work with the clinical teams, with the VHA and others to do full reviews, and we from Oracle are not here to roll out or pursue anything that's not safe. I'm not a medical provider myself, so I'm not in the best position to determine whether or not something is safe, but I certainly take all the feedback from the report and from the committees, and we'll do everything we have to adjust the system to meet the needs that they've documented.
Thank you. And I agree. It's just really important to close that loop. And I appreciate that you're saying that you don't know what is safe, but that you are going to be listening to the doctors and to the patients and getting rid of this ghost queue, but just still making sure that those orders don't fall through the cracks somewhere else, that these checks and balances are so important for patient care. And I want to make sure that there's adequate training. I want to just mention that when we rolled out Cerner, we had a full transition period where we had super users and people who were available to come right into the clinic room and help if we came up with a glitch. There was a lot of, it wasn't just training, it was training and then a whole support staff that was there to make sure we did this right and transitioned correctly. And I hope that my colleagues at the VA get that same sort of support. And I love that you are going for something that is intuitive. Just thank you for making sure that it's intuitive for everybody and that it actually works, and even follow up afterwards. I don't want to blame the users, because I've talked with other doctors at the VA who worked with Cerner in other settings and are still having trouble with this particular iteration. And for them, it's not just aggravating and infuriating really to not be able to provide the best care, even though that was their intention and they put in that order. But it's really very risky for them from a standpoint of lawsuits and licenses and livelihoods being at risk when they don't have the tools and the training to give the best care to their patients and make sure it actually gets followed through on. So I will just conclude by saying, our veterans deserve the best care because they served our country. And I will stay on this and continue to follow up with you until we know that all systems are up and working the way they should. Thank you. I'll yield back.
I'd like to make just a statement and some comments regarding the last question. I really appreciate that feedback, ma'am. As a physician, I know you understand the criticality of making sure that we have the right systems in place. But I do want to confirm that everything that was just stated with regards to at the elbow training, super user training, that is going on today. And again, there is a proficiency check done by on computer, but after it's done, we then stay with the facility and we're making those in-time teaching moments with our folks. And the tips that we have that we send out for grant staff, that goes out forward. I know the VA already established a program where they call it Pay It Forward. So some of the training issues that was affecting that grant staff, it was not at Walla Walla or was not at Columbus. So I think it's important to know that we are trying to make sure that in real time we're making changes, not waiting till 6 months to put that into the process. We're trying to do it at the speed of delivery of care.
Can I know I'm over time, but will you please just make sure that happens at the CBOC, the community-based outpatient clinic also in Wenatchee, because they need that same elbow to elbow help to make sure that their patients and my constituents get the absolute best care.
Yes, ma'am, we're doing that. Thank you so much.
Thank you, Congressman Schreier. I now recognize myself for 5 minutes. Mr. Sargent, is the unknown queue being utilized across federal enclaves, such as, is the DOD and the Coast Guard also using it?
Yes, sir. It's in operation across those facilities as well.
Has it been a big of an issue for them as it has been for the VA? And how many orders got backed up in DOD's queue?
I don't have that readily available to you. I do know that our folks have trained and everybody in the DOD are familiar with the queue as it relates to having having heard any types of reactions to it being problematic. I have not heard that, but I will get back with you on that, sir.
Mr. Cecilia, in your testimony, you claim that there is nothing in the federal EHR system outside of your core capabilities. Can you explain how Oracle's experience in other industries will translate into EHR development?
Sure. As I mentioned, we're very active and have been very active in the clinical trials pharmaceutical industry for 15 years. We have the largest pharmacovigilance database, which is drug safety database in the world. Last year, 91% of all vaccine adverse events that were reported to the United States FDA came from that database. So we are very experienced at running very large-scale, nationwide, critical systems. We do that for the private sector. And as I also mentioned, we've also done that for HHS during the period of COVID, given the systems that we've built for vaccine safety management called vSafe, the federal ordering provider, which allows all federal providers to order directly, to order supplies, to order PPE, to order vaccines, and to order therapeutics from the federal government as needed in response to COVID. We're also, as you might imagine, now working with HHS to expand these systems to include monkeypox as well. During the period of COVID, we electronically pre-screened using our coronavirus prevention network system, which was donated to NIH, 650,000 individuals who were volunteers for the Operation Warp Speed clinical trials. So I do believe that our current clinical experience, combined with our technology and our Generation 2 cloud architecture, federally certified cloud architecture, puts us in a good position to serve the VA and to serve our veterans certainly far better than that has happened to date.
What was the factor that made it most attractive to purchase Cerner?
Well, Cerner is the largest EHR system in the world. So over and above the United States government contract, Cerner is quite popular outside the United States as well. And Oracle is a global organization, and we tend to look for acquisitions that are global in nature. Our thesis with Cerner, and we've been very public about this in our statements, is that the technology, like all of the EHR vendors, is not great. In fact, we believe that the medical community has been vastly underserved by hyperscaler-like competitors, hyperscaler-like vendors, rather like Oracle. And it's an obligation for us to fix and do better for all of our providers, government and commercial alike. And we believe that since we've done this for other industries like utilities and financial services, that we have an opportunity to do this as well for the medical community.
You had mentioned the cloud. Is there long-term plans to utilize the cloud for this system?
Absolutely. I think, frankly, that the only way this thing works long-term is to move it to a modern cloud application. I mean, the current architecture, the current technology is a bit brittle. It's a bit dated, as I mentioned last week in the Senate testimony, and moving that to the cloud, just like all these other systems that I just spoke about already run on, I think is the answer, and it makes it far more predictable, far more secure, and frankly requires less humans. And when you have less humans involved in the administration of a large-scale technical system, the less chance you have for human error.
Thank you. Mr. Sargent, has the feedback from VA been a problem? Are you clear on what is being asked and specifically on the training?
Absolutely. I will tell you, as I said in April, our relationship with the functional leaders and Dr. Ehrm and Dr. Sophocles and Laura Petrula, who's running the technical side of the house, we are working daily and at the speed of each problem, trying to resolve them in a very collaborative and collegial manner. Clearly, a medical system of this large is pretty dynamic. And quite frankly, this is one of the most Herculean efforts I've been a part of. But I do think that we are working very well together. But I want to make sure that as we look at the system, as Mr. Cecilia just talked about, it's dated. And we believe with the Oracle acquisition that this is going to make us exponentially better. I mean, they are a force multiplier from the time I came here in April to the time that I'm here now. And I'm saying that I'm very confident as a veteran, as someone who spent 35 years in the military, all within the medical Army healthcare system, supporting folks in peace and combat, that this system, that if it has to succeed, and as Senator Tester mentioned earlier, he says, I want to be on the right side of history. I'm telling you, I think I will be on the right side of history with your support, because we got 1.2 million beneficiaries right now in the DOD. That if we don't have a system put in place, then when they retire, such as I am, that they won't be seen across that system. And I know that this process has been in flight for about 40 years almost, this discussion right here. So I do think, and I'm going to ask for patients to be able to make sure that we do the IOC checks properly. As you know, Madigan Army Medical Center in October of 17, it had the same challenges that Main Grandstaff took place earlier. We did not go live into another site until September of 19. I will tell you that we learned significant amount there, and you look at the VA DOD right now, that they are on cost and on schedule to finish in the time period that they recognize. I believe we can do the same thing inside of the VA.
Thank you. With that, I yield, and I recognize Mr. Rosendale for 5 minutes.
Thank you very much, Mr. Chair. Mr. Case, thank you so much for staying with us. I appreciate you staying on the line. Your report describes how the EHR creates a confusing matching game for employees in order to do practically anything. When someone schedules a patient for a follow-up appointment, they have to sort through a drop-down menu of all possible facility locations. We also heard that the drop-down menu of doctors includes every single doctor in the VA. How significant a cause of medical errors is this?
It enhances the likelihood of risk substantially. We see that with the unknown Q, and we've seen it in some of our other reports. Our report on medication management, as excerpted in our testimony, gives you a sense of how much a provider has to sort through simply to select a medication. When you have a system that has all these drop downs, it creates usability problems. I think that's one thing that Oracle is trying to address in its testimony. These usability problems create risk. And we've identified the risks in the areas we've looked at, and the usability problems, medication management, the unknown Q are just two good examples of that. And so it's a problem.
So, Mr. Sargent, why is the system designed that way? Why does it require a complicated software change to filter irrelevant options out of the menus?
I was not involved in the actual design of the system, and I agree with the IG that we have too many options, and it puts in more risk than necessary, and that's why we're working with Oracle to make those changes. I will tell you, though, the transitions that take place in a medical facility, from the OR to the unit, from the ER to the inpatient, from inpatient to lab, all of those transitions, that's the most critical time where risk and failures in care happen. With this unknown Q, we are now being able to go back and ensure that that transition of care that the physician asked for indeed takes place. Candidly, we need to get it to where it's a hardwire, where it doesn't go there. But this is going to help us to continue to make sure in the interim that we're having the right checks and balances. Technology is not just a single piece of this process. It is people, processes, and technology. And so right now, we got to just make sure the processes are understood and trained to ensure that it doesn't cause unnecessary patient harm. And I think that with the changes that we're getting ready to make, that it's going to make, as Dr. Fisher's and his team's job much easier as we move forward.
So I've got a little bit of time here. I want to do one more question. Mr. Cecilio, Oracle's made a major investment in Cerner, and it's because you said they were another global, again, I'll use my words, another global company, that the biggest in the marketplace to handle EHRs. Would you consider Cerner modern EHR?
No, I would not, but I would not consider any of the vendors in this space modern EHR either.
Okay. All right. Mr. Chair, I'll yield back.
With that, I recognize, thank you, Mr. Rosendale. With that, I recognize Chairman Takano for 5 minutes.
I'll just open my questioning with, it is kind of strange to hear you, Mr. Sargent, refer to by saying that Cerner is old and needs fixing. I'm sure that wasn't part of the sales pitch for the sole source contract. And I think, Mr. Cecilia, your comment about that none of the systems in place, including Cerner, you would consider modern and up to date. And so, I guess that takes the edge off of some of my little remark at the beginning. But the safety of our veterans is my number one concern regarding the future of this program. The risk to veterans' lives is too great, as evidenced by the Inspector General's report. The issue is not partisan, as evidenced by the work of this subcommittee and the full committee, and the members that we encouraged to be here today. Everyone on this committee cares about the lives and the safety of veterans. I encourage you to continue to interact with our staff, Mr. Cecilia, and highlight issues as they arise so that we don't have to hear about them in the news. We have a responsibility as we modernize not to do undue harm. I would ask you, sir, if you could provide me with your plans going forward to ensure that we aren't having these discussions again.
Well, as you might imagine, in the first 7 weeks, I've done quite a bit of diligence, further diligence on the system. I mean, there was a bit of diligence that was done during the acquisition process, but there's nothing like owning something to really expose more issues. Next week, on August 4th, I'll meet with the leadership of Ehrm, of VA, of DOD, and we will have a comprehensive governance meeting on our plans going forward. I think I'll be in a much better position to provide, and I pledge to provide these plans proactively as we go forward. As I mentioned, we'll also be starting a dashboard that all of you will have access to with the list of 36, and I expect that list will change over time. I expect it'll expand and contract as we make progress and surely run into to additional issues in the future, and to be very, very transparent about exactly where we are. And I think you'll see a very big difference with Oracle is that we'll put a stake in the ground. We're putting time frames in the ground, and I want to make sure that the team understands, and the team does understand that the Cerner-Oracle combination is that we're going to take a particular hill, and we're going to do that. And if we're not, for some reason, going to get to the apex in the time frame that we say we're going to, we'll tell you that. In fact, you shouldn't even have to ask us because it'll be available to you on the dashboard, and you'll be able to see exactly where we are tracking. I believe that transparency is the only way forward in this, as you rightfully say, moral imperative for our veterans and for their caregivers.
Well, sir, I know you can't promise zero patient issues, but I do ask for your commitment to be open and transparent with Congress, and you've already used the word transparent in the statement preceding mine. It is us, as we on this committee, who represent the veterans who are affected by your program. So that's the commitment I'm asking, is the openness and transparency. And I've heard you say it, but that's what I ask as I close out my questions.
You have my commitment.
Mr. Chairman, I yield back.
With that, we are facing closing remarks. Mr. Rosendale, do you have any closing remarks?
Just real quick, thank you so much, Mr. Chair. Everybody understands and senses, I am sure, the frustration that this committee has had with this entire EHR rollout. And all I would like to say is we will be watching the rollout of the EHR and its progress and its cost as we move forward. And hopefully our hearings will be better in the future. Thank you.
Thank you, Mr. Rosendale. I now recognize myself for my closing statement. I wish I could say that we have heard today gives me confidence that this program is going in the right direction. Unfortunately, that is not the case. This program has real issues with leadership training and communications. Governance, change management, you name it. I highly recommend that VA and Oracle Cerner take advantage of the delay in the next go-lives to make real and meaningful challenges. This system and deployment has caused harm to veterans. Our committee will not tolerate this. You must do right by the sites you've deployed to and the veterans impacted by this system. The future of this program will depend on it. With that, I adjourn, and all members will have 5 legislative days to revise and extend their remarks and include any extraneous materials. This hearing is now adjourned.